Good afternoon and welcome everybody to this meeting of the Leicestershire Health and Wellbeing Board. The meeting is being broadcast live via YouTube and it will be archived so you can view it afterwards. Please turn your microphones on when speaking and turn off afterwards. Thank you. Apologies, we have received apologies from Councillors Cheryl Cashmore and Sarah Prima. Are there any other apologies? No, just running late. Oh.
Yes, Fiona Barber, and I'm covering for her today, Hodip Chauhan, for those that don't know me.
Moving on to item 1, minutes on pages 3 to 8. I propose that the minutes of the meeting held on the 28th of September 2024 are taken as read, confirmed and signed. Is everyone okay with that? Thank you. Number 2, urgent items. Given the increasing pressures on urgent and emergency care in Leicestershire, I have asked for an update from UHL and ICB on the current situation. So, Rachna is here. Sorry, I couldn't see you, Rachna. Rachna Vyas is going to say a few words once we've covered the other agenda items. I've also covered this issue in my position statement. Item 3, declarations of interest. Do any members have any interests they need to declare? No. Thank you. Next, we have my position statement, and you have had copies of this emailed to you, and there's a version will be published on the council's website. I have a couple of additions that I have been involved in an ICB-ICP Chairs Forum on the NHS 10-year plan last week, and also attended a mental health collaborative away day and the NHS Confed conference. Going through my position statement just quickly, just to flag about the extreme pressures the NHS are under at the present time, and would ask people who need some health support to look at, pharmacy first, your GPs, your health professionals within the practice, if at all safe for you to do that. Just helps care, and 111 as well for any advice you may need. This will help, especially emergency care at the NHS at the moment. Thank you. I would ask people to take a look at the Health and Wellbeing Annual Report. It really does spotlight all the work that goes on collaboratively in our area. And there's a lot of very interesting articles in that. And I think it was great to have health within the local transport plan for this year. That will go out with a joint forward from 3 areas of the council. So I think that's a real move forward. So I appreciate Environment and Transport in linking up with us on that. Does anybody have any questions or any comments? No. Thank you. I'm going to propose we take item 15 first on the agenda. Ed has to leave later, so if everybody is in agreement with that, we'll move to item 15. So this is the Staying Healthy, Safe and Well Development Session, Outcomes and Recommendations, pages 441 to 444. This report presents the outcomes and recommendations highlighted at the recent development session, themed on the Staying Healthy, Safe and Well Life Course priority. And the joint chairs of the Staying Healthy Partnership, Mike Sands and Ed de Coverley, will present this report. And I will say it was a very good development session. I'll leave it to you.
Thank you, Chair. And this is where me and Ed look at each other and go, which one of us is going to go first, because we haven't prepped this one. But I was going to start on that one. So obviously, thank you to members of the Health and Wellbeing Board that did attend the development session. hopefully the paper that's in the pack kind of you'll recognise from your input in terms of what we covered at that development session. It was certainly really useful for me, and hopefully I think Ed as well, in terms of, I don't want to say get things off our chest, but as co-chairs we would appreciate the depth and the breadth of work that the Staying Healthy Partnership has got, but in some ways that's been a problem too. It's almost such a broad area that having that kind of focus and thinking about what is the role of the Staying Healthy Partnership in relation to the work that all the partner organisations are doing has been a tricky one. But at the end of that, and I think it's paragraph 12 is the key one for me, I think there's a clear sense in terms of those group discussions that the Staying Healthy Partnership, and this is what we're putting forward to the Health and Wellbeing Board, should really be recognised as the place that holds the ring that drives work in Leicestershire around essentially the wider determinants of health, which of course then covers a multitude of partners and issues, work, employment, income, education, etc., and thinking about how we use that to amplify the work that's going on within public health and the county council, our partner organisations in district and boroughs in particular, the role of the NHS as anchor institutions within the NHS. And then obesity, and again, very much stuff that we've talked about before, but making the Staying Healthy Partnership the home for that whole systems approach to tackling obesity within Leicestershire. So not just about weight management services, but the role of communities, us all, planning, regulation, etc., in helping to tackle obesity locally. So I think that's it for me in terms of just saying thanks and reflections on that, and a sense of those are the recommendations in terms of what we see the Staying Healthy Partnership as being. Again, not to say for either of those two areas that we're starting from scratch, but it feels like those are the two big issues that need a home, which hopefully the Health and Wellbeing Board would endorse Staying Healthy Partnership, really pushing partners on action on both. But Ed, I don't know if you want to add to that one.
Yeah, thank you. Certainly just to echo everything that Mike has said, and my appreciation for the contributions from partners at the development session as well, which was really helpful and constructive and honest and critical and engaging. So all the things that you would hope from that kind of open dialogue. The agenda is so broad, isn't it? And the focus can be so broad that it can be overwhelming at times. So I think just trying to have a conversation with partners where we can collectively agree what that focus should be was really helpful. And I think we have got two areas where I think we can make a tangible difference if we focus, and there's some genuine and real things that we can do. So really endorse what came out of that development session, and I think there's plenty that we can get our teeth stuck into on the two items that are before you today. But to certainly reiterate Mike's point, that's not to say there isn't good stuff happening already. It's just about adding value to that, and particularly with the strategic heft that is in the room in the SHP and the leadership capability. It's about just giving additional permission, vigor, and kind of hopefully some pace to some of that as well. So that's where hopefully we can add value. I think just the other thing I would touch on as well is I guess a side note really around what came through that meeting loud and clear to me was a real determination to look beyond organisational boundaries and a real desire to kind of work in a system leadership way, not to be territorial about things we're responsible for, but particularly on things like the healthy weight, how we work together to make a real impact in our communities. So yeah, really good discussion, really good to be part of, and yeah, welcome feedback from the Health and Wellbeing Board, and hopefully we can agree something to take forward. Thank you, Chair.
Does anyone have any comments or any questions for Ed or Mike? Yes, Marsha.
Hello there. So from my role with Voluntary Action Leicestershire, really pleased to see next steps, including the voluntary community and social enterprise sector. But from my Health Watch Leicestershire hat on today, just a couple of the questions that you'd expect from Health Watch was that our role in involving the public, and when it comes to looking at outcomes and reviewing those outcomes. So just wanted to flag that, and also just say that as Health Watch, I know we have been involved in the conversations, but would welcome an opportunity to have discussions around that a bit more, if that's okay with you guys.
So I think the answer would be yes, but that's remind me. I mean, I've been thinking about how do we engage with the public. We'll take obesity. And now we've got the health determinants research collaboration money. Obviously, we've got a kind of in-house, if you like, vehicle to engage with the public about their attitudes towards food, the food landscape, takeaways, etc., etc. Does Healthwatch's remit extend into that kind of broader bit, or is it just around health services? I'm just wondering if there's a role for Healthwatch in terms of that broader engagement piece about influences on health.
Yes, it does extend onto that. We do look at that on a case-by-case basis, but we have been approached, we as in the provider, Voluntary Action Leicestershire, around some of the work to do with obesity, healthy eating, food banks. So some of the things that we've looked at the moment is around whether there are any voluntary community social enterprise organisations that tackle that and just that, or are they doing it as a broader piece of work? And that's when Healthwatch could come in, because they could engage with those groups, those beneficiaries. So yes, we can do, in short.
Ed?
Yeah, no, I mean, it's really helpful. Thank you. And I think one of the key things we discussed at the meeting was recognising that not all partners have the same interest in all the matters before us. So it's about tailoring involvement and contribution to the things that are going to make a difference. So the group that we pull together to talk about planning is going to be a different group that we pull together to talk about obesity. And that's fine. There'll be a core that cross both, but we'll adapt it and be very kind of task focused on the issue that we're confronting at hand. So yeah, really be good for you to be involved in that. Thank you.
I think that flexibility in all the work we're doing, I think with the health and wellbeing development session, board development sessions, and ICP and all this subgroups, I think to have that flexibility to pull in the relevant people so that we have that broad discussion around it right across the system is really, really important. But thanks for everybody's engagement in that development session. I found it very helpful, and we can move forward. So we're being asked to that we agree to spotlight the following priority areas. That's the health and the strategic planning system and the healthy weight. Are we all agreed? Yes, thank you. We'll now go back to item 5. This is the progress report on community health and wellbeing plans, pages 9 to 28. This provides an update on the progress of the 7 community health and wellbeing plans across Leicestershire, and Jo Clinton and Sarah Lewis from the Integrated Care Board will present the report. Oh, Sarah will.
Yes, apologies. Jo Clinton's full of nasty bugs, so has thankfully stayed well away. so thanks. So yes, this is just a brief report on update of the 7 community health and wellbeing plans. They're regular updates taken to the Stay in Healthy partnership as a rule, but at the last meeting of that partnership, it was agreed they just wanted to bring an update here to the Health and Wellbeing Board, really to highlight mainly the recent changes to some of the working practice we've put in place to try and improve alignment across system, place and neighbourhood level to address some of the quite valid concerns around is there potential for duplication and crossover here. So I'll do a very brief update to you around the plans just to keep you all up to date while I'm here, but then I'll sort of outline what those changes are just for information. So as I'm sure you'll well know, the community health and wellbeing plans were developed on a neighbourhood footprint just to reflect that variance in needs of populations across the county within the various districts. It's to really get a detailed, in-depth understanding of the health and wellbeing needs of those local populations and to address key priorities and own those as partners across those neighbourhood areas. It's also key to note that they need to both inform the Leicestershire-wide joint health and wellbeing strategy and respond to those priorities as well. So this is part of what this work was about, to try and align that place and neighbourhood relationship and work. All the plans have followed a robust process, which has been discussed before to, as I said, identify appropriate priorities that reflect their local needs within those districts, and are collaboratively owned by all partners who attend and have taken part in that process, which is really, really key. These plans don't belong to any one organisation, they're partnership plans, absolutely. There is an Appendix 1 that sort of has a summary of the updated status of the plans and the identified priorities, which I won't go through in detail, but just an update since this report was done. 5 plans had already been approved and were in the delivery phase. Wellbeing, Wigston and Harborough were the outstanding 2 plans. Pleased to say Wellbeing and Wigston was signed off by their partnership board last week, and Harborough is due to go to their first partnership board next week. So as soon as they've been approved or in a position to, I'll make sure that they are circulated and brought to Staying Healthy Partnership and the Health and Wellbeing Board for information, so that everybody's aware of what's been agreed within those. But that's really great that hopefully by Christmas we've got all 7 across the line in various levels of progress. Just sort of information, just some of the emerging themes. So obviously there's some nuances and specific priorities within each area, because as we said, they're different populations, but there did seem to be some overarching themes, which I'm sure will not be of any surprise to any of you around this table. The first one is a massive increase in improved access and support for people of all ages. So from babies up to the elderly population with mental illness or a mental health issue. A lot of this has been in response to the pandemic and then the cost of living crisis, and it's had a really major impact that people are seeing on local populations. And as you know, it's across the whole system and place. They're seeing an increase in the numbers of people presenting for the first time, and also in the acuity of people presenting with mental health support. So that's one thing that's just been across all 7 districts. Another big issue that has come across, which again may or may not be such a surprise, is a real lack of understanding between us as partners, between the range of services that are being provided out there. It's become very evident there is such a vast amount of amazing services being provided by all partners. And the heartbreaking bit is sometimes we don't know about them, and we don't know about the referral pathways. Then when you start bringing in how do the public know about them, that's a whole nother ball game. So there's an awful lot of discussion and a lot of work going on between partners of how do we sort this, how do we map this, how do we get to know about what each other's doing and how to refer to each other, to make sure that residents and patients are going to the best service in the best location for them. And there is so much work going on about that, but it's a really tricky one to do, and it's huge. So there's things such as the recent procurement and implementation of the Joy platform, but also the acceptance. There's some really great things already out there. First Contact Plus people use really effectively. Some of the districts have got local databases. Val, I know, has got lots of database and information. And this is where we need to get away from, there's not one better than the other. It's what works best for the right people, and actually how can we support all of those to help people, not just ourselves but the public, to get a better understanding. And sort of alongside that as another stream is virtually all the plans now, although they may not be specifically a priority, have a cross-cutting theme around communication. So how do we communicate with each other as partners? How do we communicate with the public? And also, how do we communicate not just services, but get some of the great stuff that's being done by all of us out to the public, so it's not always doom and gloom that's on the news, but actually we know things are difficult, we know things are challenging, but these are things that we have done. So there's a lot of work going on with that. It's a very difficult thing to do, and a lot of this is being done already, and it's as I'll go on to later, linking in with what's being done at a system level, what's being done at a Leicestershire level, what's being done by different organisations, and how can we help each other out to do that and share that. And just an extra one to which sort of came to me while I've been sitting thinking about it, is a lot of the interventions, when you look at what they're trying to do locally, is very much focused on prevention. They're lower level preventative interventions, very much aligning to the recently published Darcy report. And I just think it's really important we don't lose sight of that, especially because prevention's often the poorer relation, that you don't spend money in there and get big bangs bucks in savings. You spend money up front to see the benefits years and years down the line. And I think a lot of that is coming out of how important that is. And I think it's just really needs to be in our minds that it may not deliver something quickly and it may not save a lot of money quickly, but it's absolutely the right thing to do. And we need to think, how can we support to do that even more? So they've sort of been the main themes, very broad brush themes coming across. So moving on really to the main bit that we wanted to talk about around the changes in working practice. So there, as I said, very valid concerns have been raised about the possibility of duplication of work, putting these lower level plans in place. We could see the benefit of getting it locally focused, but actually what we did not want to do, these plans come with no funding and no workforce and no capacity. So what we cannot do, and nobody can do, is afford to duplicate and waste resource. So in order to address this, now that we're coming to the stage, we know all the priority areas, we're getting main themes across and getting a better understanding of what's coming out at the district levels. It almost naturally came out that a lot of these priority areas, when we sat and looked at them, have an awful lot of work that's already being done at either a system or a place level, which actually is really reassuring, because it shows that what's being prioritised at say Leicestershire or LLR level is actually being reflected down at the district level. So where we've identified that, and as I say, it is a big majority of the priorities, what we have suggested and implemented is that absolutely we'll have a priority lead at a district level who's identified, who's got that local ownership. And we'll also identify, because what we have found is that several districts have the same priorities. So why on earth start working in silos when actually let's come together, let's learn from each other, and somebody nicely put it, unashamedly steal ideas from each other, because it's absolutely what we need to do. What we've then tried to do is determine who's the most appropriate either place or system level lead who's leading that work at that level, and make that link between the district and that Leicestershire or LLR lead, so they can have a discussion and understand what's the governance in place, what is already being done, and how can districts link in and help that, rather than districts go off and do their own thing. A lot of that was already in place. So, for example, a good example of this was around falls. That came up as an example priority in several areas. There's a very well established LLR falls steering group who are doing a lot of great work. What was coming back in the district feedback from those priorities is we're linking in, we sit on that LLR steering group. So actually, the most useful thing to do there is have open and honest conversations, back to the conversation we've just had, putting organisational boundaries aside, place level boundaries aside, and have a conversation to say, where best are actions done? If they're best done at a system or Leicestershire level because of economies of scale and it makes sense, perfect. Districts know that's what's being done and can, feed in and influence on that. There are some elements that are much better being fed down, saying it's really good for you to do that locally. A good example is particularly trying to engage with local communities or specific communities to certain areas within Leicestershire. So it's really opening that conversation of it's not place, it's not district. Bring districts to the place, say, what's going on? How can we help you? Is there anything that you want to know from us? Is there anything we can take away from you and deliver more locally, and keep that two-way conversation going? And that's what we've tried to do. The other issue is obviously capacity for people working at, say, Leicestershire or LLR level. Very often there's one poor named lead doing that, and then you may have 2, 3, 4 plus district level leads who then want to get that information and link that in. What we've done is coordinate that, so that one place lead, the district leads go to them once, so they don't have to go and meet them 4 or 5 times, because that's just not realistic. All of those district leads, for example, who are leading on falls priority, will meet the LLR falls lead once and have that discussion, and then it's between them to decide, do we need the district leads sitting on the LLR or the Leicestershire level meetings? Do the district leads need to go away in conjunction with the LLR lead to go, this would be useful for you to go and do a specific piece of work within your area? But there's clear communication, there's clear agreement on what level it's best done to for certain activities to be done at what level, and there's not going to be work going on that they aren't aware of each other. So what this really should do is it's a joined up approach, and it's a teamwork, and it's a partnership between two different levels as well as different organisations. It gives us the opportunity to have these discussions and make sure that actions are carried out at the most appropriate level, whether that be at a higher level or whether that's a more local level. It enables system leads to have a clear contact list of district leads to contact, so they haven't got to find out who it is. And it streamlines it for those system leads to enable them to meet with all the relevant district leads once, instead of having to go to various different districts. So the sort of priority areas that this is start being implemented and we're trying to improve and work with is around the ones that I'm sure you'll be aware of, around cancer, carers, diabetes, dementia, falls. They're listed within the report. What I would say, I think if anybody's sitting around the table here thinking, I know I've got members of staff being pulled into that, please let us know, because we may well have missed any. And what we want to do is make this work for everybody and make it efficient, because as I said, nobody's got spare capacity about this, but let's use each other and make sure that we're doing things once and in the right way. I've just quickly added in there, just for completeness, mental health. We're not touching that because that's working so well with the mental health neighbourhood leads. That structure's set up really well, and we're not going to mess with that at all. It's resourced well and it's working excellently, and particularly because it's such a priority area at the minute, that's being really successful. There are a few other areas that aren't particularly system leveled at all, but they are, as I referred to back, across more than one district. So where we said if you can beg, steal or borrow from each other, learn. So there's a couple of examples there, such as Hinkley and Bosworth and Oby and Wigston have both identified housing quality. So it might be slightly different for both. There's no big LLR system around that, but we're putting them in contact, those district leads, to say, see if you can share, see if you can help each other out, because it's silly you doing things twice each. So that's really what we've been trying to do, and hopefully the board will be reassured that that's the right way to go. I'm not saying we're there yet, but we're trying our hardest to get that to grow. Just while I'm here as well, there are just a couple of areas of concern. So that was one of the areas of concern. As I said, we're not there yet, but it's improving. Already you can see those improvements, and I would just keep asking for any feedback and any concerns to be raised so that we can address those. The other one is around, again, because of capacity, we did ask the members of the Staying Healthy Partnership just to emphasise the need for all these are partnership plans, they're not one organisation's plans. So we all need to take accountability and responsibility for interacting and supporting them. I think as referred before, some priority areas are going to be more relevant to some organisations than others, and that's absolutely fine. But it's just where we can. We're trying to encourage a real open culture of, if people are struggling, please speak up, because it's not a blame culture here. It's if one organisation's struggling to provide capacity, let's have that open conversation. Let's see what we can do about it. Let's see if others can step in, or if we need to park something, or let's be realistic, because what we don't want is a big long list of priorities and then come back with nothing to show for it. We want to make these meaningful. And finally, just some areas of celebration. There are some good news stories. I'm not going to go through them, but appendices 2 to 5 just outline some really lovely case studies and good news stories. And this is the sort of thing, going back to the communications, I think it's really important that we get better at sharing these with each other and with the local population as well, to see what we're doing. We're not going to change the world in one day, but there's some really good things that are having really big impacts on people. And I just wanted to add as well, I'm just really proud of the relationships and partnerships that have been growing between us all. This has been a long process, and that you can see them developing. And there are just a couple of shout out. I particularly wanted, Simon, actually, I wanted to shout out to your strategic partnerships team. Mohammed, Erin and Jane, we have UHL sitting around the table at every partnership meeting now, which is brilliant. And actually, I think Erin's delivering a little slot at Blaby, which is fantastic. Charnwood partnership meeting for the first time a couple of weeks ago, we had a pharmacy rep, the acknowledgement that primary care is not just all on GPs. We've got pharmacists there, like Pharmacy First, so we've got them come in. We've had discussions with police and fire, we'd love them to be there, but we need to be realistic. They don't have the capacity. So what we're doing is we're making sure that the likes of me are going to the community safety partnerships and we're bringing that back. So it's trying to flex that we're realistic with people's capacity, it's appropriate, but we make sure we bring in as much information and get people involved at the right level as much as we can. So if that's okay, Chair, I'll finish there. If anybody has any comments or queries or questions, please do feel free to ask them.
Thanks, Sarah. I have to say, you know, capacity and duplication has been one of my things from the word go. So I'm really pleased that you're looking at it. Do you feed into the joint comms that we have with ICB and local authority, etc.? Because that's a place where we could tie up if you're not feeding in, because I made a point of trying to get us all involved. I don't know whether you're involved in that.
We don't have a formal feed into that, but I think as we're going along, communications is getting so key. I think that would be an excellent place to feed into, actually. So that would be great if we can facilitate that. Yeah, thank you.
Okay. And I was going to ask you about the mental health, how you, if you flagged things that you were seeing across the board, do you feed that into the subgroup of mental health?
Yes, absolutely. So that feeds into the Leicestershire Mental Health Group. We also have very close connections with Rob Mellin within LPT, who has oversight of all the mental health neighbourhood leads, who, to be honest, are doing all that, pulling all that great work together. Because as you said, it is absolutely huge. There are some nuances, but a lot of it, we're having the same conversation going, yes, this is happening, this is happening. And like you said, we need to make sure that's happening, not in a siloed way, but we're learning from each other and we're doing it cross county wherever needed. And I can see that I think their network works so closely together. And that update then from Rob, Verity and myself at the Leicestershire Mental Health Group can bring that to make sure that they're assured that that is happening appropriately.
And just last one from me. When you mention about either system or place being the key and you have leads, I think the communication still has to be there for the other party, because if we were running some system and you went to ICB, then that's where the duplication comes in. So if we're aware of things, so I think we need to make sure that we do that.
Absolutely. Yeah, absolutely. We'll do.
Anyone else? Yes, Kevin, sorry.
So on, I think you know what I'm going to say, Sarah, which is I know things have got better, and like I said, it's well, you know there's been progress in this, but as a sector, for the voluntary sector, we are still slightly out on the periphery. And as I mentioned at the Staying Healthy Partnership a while back, we know that obviously these plans are going on. We know that certain voluntary organisations are being brought into these discussions at a district level. We don't know who. And I did ask at that Staying Healthy Partnership meeting a while back this year about whether I could see who, because then at least then we know who we can direct things to. The other bit as well is it really would be good in the new year if we could sit down with you to talk about how we can embed better that understanding, that information, that comms, because we're sitting on a database of over 5,500 voluntary organisations, and a lot of them are those grassroots groups. About 85% about grassroots groups out in districts who, for them, just to know somewhere, or if they've got someone coming to them they could refer on elsewhere, it would be great to link them in, because as I keep saying, the Joy app, whilst it's great for what it does, won't do everything for everyone. And I know we're aware of that as well. So again, it's about how we ensure that we're linking all the relevant parts of the sector in. And also, as I said, it just means as well that when we know about things going on from a VAL perspective, we can push that out as well. And we know who not to push things to, because we know they're linked in. So we don't want to make it like duplication and unnecessary effort, but we can make sure that other groups across the districts and across the county wide can be fed into. That was all, but it is great. It's great to see progress that's being made. I just want to know, what can we do to help you get the voluntary sector bit further embedded?
Yeah, thank you. And one of the things that has come out to me of those types is how incredibly important the voluntary sector are in all of this. And I think across the districts, there's different levels. I think some areas are brilliant just because they've been going longer in the partnership workings, because it takes time to evolve these. So some are great, and I absolutely accept some aren't as good. And we are trying to work and we need to do that as quickly as possible. So, and apologies, you did absolutely ask for that data. I know somebody was looking at it, so I will chase that up so that you know who that is. Because again, I think depending on, we have 2 partnerships where the vice chair is a voluntary sector rep, which I'm really proud of, which is great. And they're like the best, but we need to make it better and that it's good for all of the districts, because it's very much starting to click people. Gosh, there's so much stuff. And I think that's one of the areas that we really don't know what's out there. And the amount of times the voluntary sector goes, oh, we do that. And you're like, that is amazing. We didn't know. So I would absolutely love to follow that up around the comms, and I will chase that up. And I think we need to, we will keep progressing with this. And I think voluntary sector is probably one of the earlier relationships, and some have got further than others, but absolutely recognise how key they are to everything, especially this low level prevention and this real understanding of the population, because that's a difficult one to go, engaging with the population to get that balance right of death by consultation to making sure we hear a valid voice. So Health Watcher on the partnership reps, voluntary sector have incredible local intel of actually this is what we know people are asking for, and it's making sure we get enough of that in and at the right balance. So thank you.
Mike?
Yeah, thanks, Sarah. The update's much appreciated. There's 2 bits to this one. There's just going to be a note to self, which is in reference to previous agenda item. When we do have that focus on obesity, it's useful to know that kind of Blaby and North West Leicestershire have got it as a priority. So I was thinking, we must remember to bring them in. Vice versa, could you just make certain that they're aware of kind of what we're trying to do around Staying Healthy Partnership? And I'm sure we'd get good district representation, but we might want a bit extra from those localities, or indeed, I think the 2 that are looking at housing quality, Hinkley and Bosworth was one, I think Oby and Wigston was the other. Same sort of thing, you know, if we do get something going on there, then it'd be good to bring them in and let them know.
Yeah, absolutely. I wrote those down as soon as you guys said it, because I thought we need to make those links. Now, if any priorities change or as the new ones get signed off, we will absolutely make sure that we link in with the priorities with the Staying Healthy Partnership. Thank you.
Ed?
Yeah, just to echo really my appreciation for the work that's being done and the support for the recommendations. I think the opportunity to kind of review the standing groups that we have against the kind of more targeted approach that's linking system, place and neighbourhood is really welcome, actually, and I think will just lead to more productive discussions. So I think it's timely. I think, Mike, again, sort of note to self, at the next SHP, we can perhaps give a bit of space and time to look at where you've got onto in the detail, and also any gaps you've got and whether you need any further assistance from us. So yeah, subject to the board agreeing today, very happy to take that away, Chair.
Hardy, and then Simon.
Hi, Sarah. So it probably come as no surprise that mental health is one of Health Watch's priorities. But what we've said is we're focusing on young people, and we have gone back to CAMS on the recommendations we made 5-6 years ago. But I'm quite interested in the emerging themes, first bullet point, a need for improved access and support for people of all ages living with a mental illness or mental health issue. And just if you had any other sort of further information about that bullet point.
Yeah, I mean, that's very wide ranging, because it's across all the districts, there are some specific areas. So for example, within child with teenagers was a specific area. And actually, if things have gone, some have been in place for 12-18 months, these plans, some more emerging themes have come. So what has been found is, unfortunately, because of the cost of living crisis, a lot of people on the ground, such as mental health coordinators, voluntary sector, are saying there's a real need now of people with mental health problems, which actually caused by financial issues. So it's a mental health issue, but actually what they need is not particularly mental health intervention. They need someone to sit them down and talk them through the benefit. And that's where the likes of the voluntary sector. So rather than going to their GP to get prescribed antidepressants, they don't need that. And GPs are saying that's the worst place for them to be. What we need is a community and voluntary sector people to sit down with these poor people to help them. So that's been this is where it's sort of the lower level, and we're trying to get hold of them before they reach crisis and end up at the GP or the mental health crisis, to try and get that intervention of what is it that they actually need, what's the core of it. And in children and young people, a lot of it has come around from the pandemic. It's bizarrely, because they've permanently got their faces on a phone, it's isolation and that social interaction. So that's where we're finding this local intel so useful with people on the ground in, say, those areas, saying this is what we're finding when children are coming through the door, this is what we're finding when adults are coming through the door. Heartbreaking, a whole family were nearly on the railroad tracks in Charnwood because they couldn't pay the rent and were facing eviction. That doesn't need an antidepressant, that needs someone to sit with them and help support them through, and that's exactly what was done by a voluntary sector. So that's sort of the big things that are coming through, along with all the usual, things that are coming. But the big increase in surge seems to be around that adult, more unfortunately, a lot of the middle-aged males with the financial burden on their shoulders around that. And then with the children, it's this isolation and the social media.
Simon.
Thank you, Sarah, for the update and for the positive feedback. We see the role of neighbourhood as vital for us in terms of listening, reflecting on what we hear, and then shaping our service offer around the needs of those at neighbourhood. It's a key enabler for us for delivering on our commitments in the Darcy report. And just to close, I think we're going to be focusing on turning what we listen and reflect on into action. So over the next 12 to 24 months, you can expect to see tangible actions from us at UHL on the back of the learning we have from the neighbourhood team. So thank you.
And Nichols, I think we'll make the last on this one.
Thanks, Sarah. I just wanted to kind of mention a lot of the priorities listed are the responsibilities of the integration exec to deliver. So how do the community plans feed into the integration exec? And then the other thing was, and I hope I've understood the role of the priority leads here, but will the priority leads feed into the integration exec? So there might be the same question, really. And then the other thing was, will the priority leads link in with the clinical leads in the ICB? So the cancer leads, stuff like, long-term conditions for diabetes, stuff along those lines.
Yeah. Oh, sorry, I don't turn mine on. Yeah, so absolutely. So in terms of the integrated executive, you're right. A lot of the priorities do feed into that. And what we have is a mapping of every single priority across the 7 districts and which health and wellbeing subcommittee they feed into. So an update does go to every integrated executive. At the minute, it comes in the form of the quarterly highlight reports that are produced. And I suppose the question that's been, is put to the integrated is that right? Is there getting a balance between too much information that no one in all the best wishes is going to have time to read through, but to having enough information that enough? So I suppose I'd always say that question back to say is it fit for purpose? And I know Mike and Josh and I have had a conversation around can we tweak the reporting a bit to the Staying Healthy Partnership to perhaps then chunk it out into the execs as a little bit more written. Otherwise, you're getting to the stage of you could have district leads having to come to everyone. So I'm very happy to hear the feedback from what would be useful from you guys sitting on those as committees to get that balance of enough, but you're not getting overkill by too much. And vice versa, yes, the priority leads produce those highlight reports, so that's how they feed in there. In terms of the clinical leads, that absolutely right. While you were saying that, I was thinking, I think I want that written down to make sure that is absolutely happening, because we've always been very clear for each priority, where appropriate, we have a priority lead, but we need a clinical link in there who's really got that specific specialist expert knowledge. But that is something that I'm assuming is done, but I will make sure it is absolutely, because I think a lot of them are priority leads or linked in. But yeah, I will confirm that because that is a really, really important point.
Thank you, Sarah. I think there's been some good points made, and I think, we started it off about communication, and I think this is about making sure that Health and Wellbeing Board and the relevant subgroups do have the right information so that we don't, we understand what's going on within the system. And the same, obviously, you come to hear back from health and wellbeing boards. But I think, you know, taking the point with Kevin as well, I think it just shows that communication is key in all of this. Right, so we are asked to note the progress of the 7 community health and wellbeing plans within Leicestershire County, and note the areas of concern and celebrations outlined in the report, and note that future updates will be provided via the Staying Healthy Partnership update report or directly by exception. And I think that's where we need to link into integrated exec and mental health, etc. Is everybody agreed?
Yeah.
Thank you. Do you need some water, Christine? Thanks very much, Sarah. Next item on the agenda is the Workwell programme update, pages 29 to 140. This report relates to the delivery plan for Leicestershire, Leicester City and Rutland Workwell, and how the programme will be placed in general practice to support the population that may have barriers in returning to work and thrive in work. Louise Young and Glenn Halliday from the Integrated Care Board will present this report, and I'm very pleased with how well this has gone through the ICP and how well the officers have pulled this together in such a short time, so thank you.
Okay, so brief update. It's the first time it's come to work in the Health and Wellbeing Board. So Louise Young, I'm Deputy Chief People Officer in the ICB. So essentially, as chairs confirmed, this is one of our first partnership arrangements through the ICP and a key piece of work that we're progressing. Workwell is essentially a low intensity support offer. It is not something new, and linking back to the previous item, it is about how we connect together all the existing services and offer a gateway to those individuals who are struggling with either long-term conditions or disability to remain, return or stay in work and employment. And this links to a wider economic crisis we have nationally around the number of unemployment we have in this country, which is still at the current pre-pandemic levels prior to COVID. So it's a national priority. Nationally, we've been advised LLR is of significant interest at the moment. We are the only system in the east of the region to have been successful in the bid, and we're the only vanguard, one of 15 vanguards, to have a delivery model which is based predominantly on wider partnership and through a primary care network model as opposed to a single provider. So there's a lot of interest in this. Bringing it here today for 2 reasons. First and foremost, to share an update on where we're at ahead of mobilising the service, and post then it will go through the integrated care partnership. And secondly, to ask for your support from a Leicestershire perspective at a place level. So just by way of a brief update, and I'll assume the paper's been read. From a policy perspective, this supports the drive to integrated neighbourhood teams. The model is around delivering through our 26 PCNs. At the moment, we have got 22 PCNs onboarded. And the model is very much looking at how we integrate additional capacity through work and health coaches into the care navigation teams at PCNs. So there's a lot of work going on in that space. We were due to mobilise in October. We've had some significant delays due to the DPIA and the data sharing agreement. And I think this is one to know as a vanguard for how we start progressing an integrated care system and some of the challenges that's posed. We've managed, I'm pleased to say, we've overcome that, and Glenn and team have done a huge amount of work, but we've now got the data sharing agreements progressing, and we have to return 22 backups Department of Work and Pension to make sure that everything's in place ahead of mobilisation. By way of an update, the vision for Workwell is probably fair to say that this was around how not only we measure the impact of the Workwell Vanguard on participants that progress through the service,
but how we measure the partnership model for LLR. So how we deliver this through a whole system partnership. And I think the early fruits that are starting to show are to have engaged across the whole partnership very early on, and to have mobilised within 6 or 7 months is actually quite phenomenal. This is a really rapid programme that's delivering at pace, and we've got a whole partnership approach, but also a lot of engagement. So PCNs in particular, to onboard 22 in the space of 2 months has been quite phenomenal. So in terms of where we're at, absolutely partnership approach. We were keen that this was locally determined. It was 100% in collaboration through health, care, Job Centre Plus, local authorities, and very much testing the integrated work and health provision across pathways and place. And with us being one of 15 vanguards, we're taking a very sort of learning approach to this and a continuous improvement approach. So principles we set out were around how we meet the national requirements. Part of that is around work well. It is very much around tackling local priorities and priorities for LLR and Leicestershire. So health inequalities. We know good work is really important for people's health and mental health. So it's about how we support people to get back into work, to remain at work, to stay at work. For LLR, our key cohort areas and participants are very much focused on mental health and musculoskeletal, which is partly driven through our pockets of inactivity, economic inactivity, and areas of deprivation and long-term conditions. We're working in partnership with local authorities, and Mike in particular is our key link from county and through public health into the steering group. For us, this is around social value. It's how we support our local participants and our local population to have the best opportunity to seek and gain and remain in employment, and how we reduce financial burden, partly into the system, but also how we heard earlier that some of this may not just be a mental health condition, it may be financial challenge, it may be, so how this signposts to the most relevant areas and services that we currently have. We've only got until March next year, so we've taken a really pragmatic approach to this. So really mapping what we've got and how we engage and pull services together. So in terms of where we're at and progress against that plan, we have the ICP fully on board and governing this programme. We have a steering group, which meets monthly now, and we have an LLR design and delivery group, which was in place and were the main partners to develop the bid, which went in last Christmas. And we're mobilising this through the three place teams. So this is really important that for Leicestershire and the other 2 places, that this is now a core component of each of those place agendas. It's really, really important because actually what we're finding out quite rapidly is the connection at each place with wider initiatives and wider partnerships, as Sarah herself alluded to. So we're taking a much more joined up approach from a efficiency and a more sort of strategic lens across how we do things once well together. PCN model, as I say, we've got 22 on board. We're aiming to try and onboard the remaining 4. If we cannot onboard the remaining 4, we're looking at the provision for the whole population in Leicester. So in county, we've got the whole of the 15 PCNs onboarded and signed up, I'm pleased to say. And we have got, within the model, we are appointing 26 work and health coaches and 4 senior work and health coaches. And there are different models of recruitment happening across Leicestershire. But we have the first senior working health coach in place in Leicestershire now, so that's on mobilising to plan. In terms of training, there's a training provision and support package in place for the working health coaches. They will absolutely link with a social prescriber model, with a health and wellbeing leads, and within PCNs, and with work coaches in DWP, but very much looking at that whole care navigation team. And obviously for county, we've got the local area coordinators as well. So how we start to evolve that workforce in a more, I suppose fair to say, a learning space, but what can we share without blurring too many of the boundaries, but by additionality. And so for the working health coaches, they will absolutely be undertaking a work and health assessment, looking at having return to work plans, thriving at work plans, and that onward referral to existing services and signposting. So in terms of the platform we're running this through, it is Joy. That was our preferred provider, and we've entered into additional contract variation with Joy to make sure that they can develop the platform in a way that will absolutely meet the requirements for this programme for Department of Work and Pension, and be able to have that case management referral in there. And from a referral perspective, it's a multi-agency referral. So multi-agencies can refer into this healthcare, voluntary sector, and that's the element now that we're trying to mobilise and point into. It's signposting. There's a signposting component as well. So if I think about Citizens Advice Bureau, we're already engaging with Citizens Advice Bureau from a referral perspective, a signposting perspective. So across the whole of Leicestershire and wider LLR, people are aware of this. We're doing the right signposting. We're getting people through the door. In terms of, I've talked about data sharing agreement, that's now moving forward. Engagement, so we've just had our steering group this afternoon, and we have just signed off, subject to a couple of changes, the engagement, communication engagement strategy and plan, and that is linking with the joint communication team, and it will be on the ICP website in terms of how we link that through and that shared communication. We're going to be doing a soft launch. I think we want to really speak to our system partners first and foremost to make sure we get the engagement right, and we're progressing from where we started and building that as we go through. And working with our external partners. As I said at the start, we've got a lot of lens on us at the moment from the National Department of Work and Pension and Department of Health and Social Care. So we're having quite a lot of wraparound support in terms of the support at the regional level and support at national level. And we're having a number of site visits from national team to understand sort of progress and challenges. We do have just a couple of additional points. We've got single points of contact at the Workwell Job Centre Plus sites, and that's moving forward quite well, and the support those sites for recruitment should some of our local recruitment plans not work at pace or need additional support. That we're happy to do. They're happy to do. And then finally, we've just had a discussion in our steering group about how do we actually engage from an active learning process around a lived experience. So for those participants that go through this service, through this process, how do we learn of those that went through that become active or remain in work with a Thrive or a return to work plan? What did that feel like? What were the learning points within that? And for those that didn't, how did that feel, and where are the bits that we can start to get better? And we're just talking at the moment about how we start this process off as it now goes live. So we recognise, because of the pace of the programme, we haven't been able to design it as such with users of the service, but actually now it's about an active learning as we start to mobilise and implement. So that will be progressed now in terms of how we onboard individuals as we go through that process. Anything? No, so I think I'll probably pause there and take some comments, Jo.
Thanks. I think that indicates how much has gone on in a short space of time. Anybody have any comments or questions? Kevin?
Hi Louise, good to see you again. It's been a while. And Glenn, apologies. I know Jenny Goodwin's put us in touch with each other and I haven't got round to sorting that out yet, so apologies on that. I just think, again, I'm going to sound like a stuck record. Can we talk to you about this? Because whilst I appreciate, I know you're talking about using the VCSE Alliance, we had a couple of weeks ago the embedding the voluntary sector into the ICB conference at the King Power. And what was coming out very clearly from that is whilst the VCSE Alliance is a great vehicle, it's not fully fleshed out yet. And as I saw from one of the diagrams, obviously in what you've put in the pack, obviously it's saying 120 members with maybe 300. As I said, we've got 5,500 organisations we can link out and into. And if you're using the Joy app, not all of them are on the Joy app, as I was just saying earlier when Sarah was doing her presentation. So I really would love to be able to have that chat about how can we try and help with the steering group, whether it's temporarily we come on it for you to help. And we'll be happy to do that as well whilst we look at the alliance, because we are having a wider discussion with Caroline and Alice in the new year about the alliance and what can Val do to try and help get more membership on that to move forward. And also just looking at the risk log you've got there was a bit about saying about engagement with partners and potential reputational risk about not having the voluntary sector involved. Please utilise this, because you do put into our contract that we have with the county council. So we're here to help.
That's great. Of course we will. And because of the links with Glenn, we're keen to do that. So yeah, welcome that. Thank you very much.
Mike?
Yeah, thanks, Chair, and thanks to the name check, Lou. In return, just want to thank you, Glenn and Rachel Parker, for all the work you've done in getting us this far in such a short space of time. I was going to make a couple of comments, one of which is related to Kevin's question. Obviously, I'm aware we had the Work Well steering group meeting before this meeting, and you talked about the soft launch. I'm thinking in paragraph 16, because it's focused on a relatively small number of wards in Leicestershire, there is something for me about the kind of hyper-local links and hyper-local advertising. And I was thinking about the role of the voluntary and community sector in that. You almost want to get below the alliance and actually just look at the individual groups, don't you? Yeah, so same point. And then I can't help but, I suppose, I don't know if I should or not, but just feeding back what OHID's regional lead on work and health said. It's probably worthwhile knowing the board. So there's a comment from Sean, who is that person. I think there's a lot of there's particular interest from DHSC and DWP, because we've gone down the route of having a primary care delivered model and kind of pulling it into the social prescribing family, as opposed to the majority of schemes which kind of are just essentially have appointed a single provider to do it all. So it's not just about the time and the mobilisation, but I think picking a model which appears to have piqued the interest of national bodies is again a really good feather in our collective caps, and you two in particular.
Yeah, thank you. A couple of questions, if I may. So just to understand the operational model, because you referred to having all 15 PCNs engaged across the county, and then obviously you referred to a number of target areas. So is there a universal offer and a targeted offer, or is it just the targeted offer into those identified areas? I think it was paragraph 16. So that was one question. The second question was then just to link back to the earlier item around community health and wellbeing plans, and you referred to kind of interactions with PCNs, but I just would like to understand if there's the connection with the community health and wellbeing plans, the district teams and the partnerships that sit at that neighbourhood level, because if there isn't, I think it's a really important connection that needs to be made. But yeah, it'd be good to get your take. Thank you.
Thank you. I'll speak on the areas of need really. So what we did for the full delivery plan was to look at the data about the most inactive area that have not taken opportunity to go back into work. So that was the single point to look at initially. But because we've got such great engagement of those, the full complement for county, it's kind of superseded that. So the model will be aligned the same for everybody, so that there will be no gaps or no health inequalities going through this programme. So it will all roll out to everybody as the same. Thank you.
In terms of your second point, it's so Work Well is just starting to get onto the Place team agenda now. I need to make those connections through with Sarah at a more granular level. So we start to engage with some of the districts, but I think we need to do that probably a little bit more as we start to mobilise, but make sure we're tying up those plans. Again, it's connecting things together. So I'll make that point.
Yeah, I mean, yeah, if I could be any assistance with that, I know Sarah certainly will be, but if I can, then very happy to as a district council representative. But yeah, I think that's really crucial, because there'll be colleagues who are interacting with DWP on the front line and housing officers and others who will be able to join the dots on some of this stuff and get the most from it, frankly. So yeah, very happy to help. Thank you.
No, you didn't look so good. Okay, take care.
I think you might have answered my question, because it was around what consultation you had with potential users, but it sounds like that hasn't happened yet.
It hasn't happened locally. I understand from the work that happened, it's built on a number of different initiatives that happened over years. So I understand there has been some engagement nationally, and purely due to the time by which the bid went in, and then we were notified in May this year that we go live. We were straight into trying to plan and mobilise, but we fully intend to engage. Probably not consult, I'd say, probably engage with participants as we go through in that active learning and shaping. If I may, Chair, as well, one of the asks of the Work Well programme is that we, as a ICS, develop a work and health strategy, and we've just been talking about that, and I think that's where some of this might play into. But the work and health strategy will very much be around the work and health, but we recognise that it will need to make those real tangible links with a broader healthier Britain, you know, moving into work, the more local strategies we've got at county, for example, industrial strategy, economic growth, but we're not planning to obviously lead that, but what we will do, we'll need to do that read across and that nod to and that alignment with as we start to progress this going forward.
Nikhil?
Thanks, Louise and Glenn. So obviously I'm aware of the Work Well kind of programme, but I don't know the intricate details, so apologies. I guess my question is, in terms of patients that do kind of see the health and wellbeing coach as part of this, are we collecting data in terms of why are they off work and, you know, the causes, so we can actually triangulate, you know, the reasons, and do we have a selection process for these patients? So is there a criteria? The only reason I ask is it's like smoking cessation. If a patient doesn't want to stop smoking, then there's no point even offering them anything further, because they're not going to engage. Same with this program. If patients don't want to, I guess, go back to work, then they may not want to engage. So are we picking, you know, those patients that really want to engage? Thank you.
So I'll start and I'll probably bring Glenn in. So we're identifying patients first and foremost through FitNote, and predominantly through first, second, third FitNote presentation, and this is purely voluntary. But of course, the whole approach is that this is here to support you, and particularly with long-term conditions, good work's good for the individual. So the criteria will be those on FitNote presentations 1, 2, 3. We need to almost learn as we evolve, as we learn through this as well. The work and health coaches will be there to use the current information, but then to build through that work and health plan on what matters to me. So what are the barriers to getting back to work? How do we support people getting back to work? And looking at the existing service provision we've got across county, for example, how do we start to wrap a support plan around the individual? So when I referred earlier to the integrated neighbourhood teams and the services that we have at health care, local authorities, it's about connecting all that together. Was there anything you want to say?
Yeah, thank you, Lou. So part of the participant's journey, the first stage will be a triage approach to assess what actual resources or services that person already taking, so there's no duplication or wasting of the program's time or that individual's time. And so part of the work and health assessment plan will go through, like it says, what matters to you, so it really pinpoint what are those particular barriers, and then looking at what current employment they do have. And then once we get to a stage where we can reach out to the small and medium employers to start that stage of the process, that will form the process of doing a bit of a joint of getting the employers on board to the programme, being aware of it, and sort of working together on that approach, and then filter into the higher need for that individual. Thank you.
Thank you. I think it was Michael, or was it Ed, who used the term strategic heft earlier? I think this is a really, it's going to be my new favourite term, I think. I think this is a really good example of when collectively health and care and local government put their strategic heft behind something and really push something, what we can achieve for our residents. And Chair, I just thought we should acknowledge that and thank the guys for their programme, but also the leadership, Mark and yourself, have shown through the ICP to get it to where it is.
Thank you. Sounds like a really exciting piece of work, and I'm aware that we are involved through some of the design and obviously through the care navigation teams, etc. And anything else we can do, very happy to kind of offer any resource we can. The one question I have is around, it's going to sound awful, but goes back to the point about how we're choosing people. So previous programs of this nature, which were driven by DWP largely, tended to incentivize, shall we say, picking the right people to get the right results. And they were based around lots of contingent liabilities. So if you didn't kind of get this many people into these many jobs in this time scale, then you had to pay lots of money back, et cetera, et cetera, et cetera. So I'm just wanting some assurance, I suppose, that some of those people who are most marginalised in terms of work, so people with mental ill health, people with significant mental ill health, people with disabilities, will have the same opportunity as people who might, shall we say, be closer to getting back to work. So we could, choose people who we know we've got a really good opportunity with, or we could choose people who are really marginalised. And how are we going to balance that kind of approach?
Thanks, Sean. Thank you for the offer of help if we need it going forward. So the principle of work well, first and foremost, is where a number of these initiatives have been led in the past, and you've alluded to it yourself, they've been purely DWP or purely health. The thinking behind behind work well is that if we go through an integration approach and we have health in the space together with local authorities and that whole integrated pathways, that we make it a more wraparound support offer, one that isn't being incentivised, and one that is truly trying to get those that are economically inactive back to work, but more importantly, those that have got long-term conditions or disability, the opportunity to get them back into the workplace or remain in the workplace. I'll be really candid. We don't know until we start to launch this what we're going to see, who we're going to see coming through. But as I say before, this is voluntary, but we will be reaching out, which is why the signpost in the referral is multi-agency. And the reason why our cohort is mental health and MSK is because it's one of our biggest areas of deprivation, cohorts that are struggling and in deprived areas. So the beauty we have about Work Well is we're learning as we go through, so we can adapt and evolve and change. So if we're suddenly starting to see slight nuances coming through, then we need to be in a position to be able to respond to those. We will be capturing data monthly now that will go back to DWP, but I think the whole difference to this is it's an integration lens. I don't know if that assures you.
Slightly. Thank you. Yes. I mean, I'm assured by the people who are running it, so that's helpful. But and the steering group, obviously. But yeah, it'd be interesting to see how we progress with that kind of more balanced approach.
Just to come in on that one, I mean, it does remind me of the conversation we had a few months ago in Mark Andrews' office over in Rutland when we went through exactly that process. If we are being candid, and I suppose full disclosure, we have got targets to meet, haven't we, in terms of the number that comes through. So I think it is a fair challenge because certainly in the early days, we need to generate numbers, which are probably, dread phrase, low-hanging fruit to get DWP and DHSC assured, whilst being mindful of, you can't ignore the really entrenched ones, down the line. So, I think that what Louisa said is right. It's about being aware of what's going on and tweak as appropriate, but there is no getting away from them. It is a bit of a target-driven culture, as we know.
Okay, thank you. And thanks for the information. We're being asked to note the update of the Work Well programme from LLR and that all 15 primary care networks within Leicestershire have signed up to host and deliver the programme, which I think is good for the county, and also support the implementation of Work Well within Leicestershire. Are we all agreed? Thank you. Thanks very much.
Thanks, Claire. Thank you, everyone.
Thank you.
We'll now move on to item 7, Better Care Fund Q2 return. That's pages 141 to 170. This report provides the Q2 2024-25 template report of the Better Care Fund. It sets out performance against demand and capacity, BCF metrics, spend and activity and statements as to whether the national conditions continue to be met. Lisa Carter, Leicestershire County Council, will present this report. Thank you.
Thank you, Chair. Yeah, so just bringing the Q2 report for noting. It is for noting because it was published at the beginning of October and had a completion date of the end of October. So it has had to be signed off by the Chief Exec of Leicestershire County Council using powers of delegation. So just to go through a bit of information on what was in this template. It consisted of 4 tabs. It's attached as an Appendix A, and you'll see it's a spreadsheet that largely has the national conditions, a confidence assessment on achieving the metric targets, updated demand and capacity, and an update against spend activity. I'll come on to section 75 in my next report. That is one of the national conditions that we do have to meet. The rest have all been completed. Just going through the metrics, there's one metric slightly off target at the moment, and that is the percentage of people discharged from acute to their normal place of residence. We're currently 0.9 off target. Yes, we're low 90%, so we're not too concerned, and we do think we normally meet that target. But yes, we're slightly off target on that. With regards to long-term support needs being met by admission to residential and nursing care home, we always have a conflict with the population data, which is partly used to calculate this information. So in year at the moment, we are down on what we were last year. So real term numbers, we are lower than 18, lower than where we were this time last year. But taking into account what they project the population is going to be, we may also miss this target, but we're not able to say at this time whether we're going to do that or not. But at the moment, it is a better position than last year. In terms of the demand and capacity modelling, you will see that there are 2 sections, discharge and community. There's some guidance assumptions there as well in one of the sheets for people to read through, should they wish to see how it's calculated, etc. Briefly, the discharge demand is higher than what we anticipated. The community demand at the moment is slightly lower overall. I don't think that's going to be a surprise to anybody. We've obviously seen much, more admissions into acute hospitals, therefore more discharge activity. And then there's the updated spend. At the moment, we are projecting that we will fully utilise the BCF funds, and it's been pre-populated. You'll see that the data from the assured BCF plans has been pre-populated in the remaining columns that aren't shaded blue. So you can see that where we've put what we anticipated against the spend. There's also activity information on there to say how many people have, we've been through those services so far, where we've got it. So that's it for that report. Any questions?
Oh, this is my favourite report, Chair. So you might want to, I'll do them one at a time, Lisa. There are some really great things in here, Chair. I think that we should really bring out, because it really speaks to some of the things that you talked about in your position statement. So a couple of things, Lisa, which are really positive. So reablement community capacity increased by 20% to support more people at home. So if you think about the shifts that we're trying to do at the moment, that is really positive and means that we are getting people back home, which is got to be one of our primary aims of the Better Care Fund. Second one, I'll draw out pathway one capacity has improved by 13% compared to the same period last year. Again, hard work of the team to get that up. I know it's been really difficult, so just to thank the team for that. Third point, more work are underway to improve the use of assistive technology within people's homes and in care homes. Well, of course, we've seen some really good pilot data on that. So just a question about scale, Lisa, and whether we can do anything faster on that through the course of this year. And then final good point before I go into my question, the intermediate care work across the system, reduction in usage of P2 and residential care overall. So again, really good for our residents, and we get better outcomes, we know, when people are in their own place. So thank you for all of that. My question is probably to do with our NHS data rather than your data, but the first line in the metrics report, Lisa says, during the first quarter of 24-25, UHL experienced an increase in attendance of 30%. We probably need to check that. This is the Q2 return, isn't it? So we've got the Q2 data. We can absolutely update that, Chair, if that's okay, and then get you to approve it if with that one change, if that's okay.
Thanks, Rachna. That's really, really good. I mean, some of the things to pull out, we have made some great inroads in terms of data and information, and that has been seen across all of our kind of sit rep reports, across all of the kind of reporting that we do, particularly around discharge. We are looking now to kind of, and I think when we went to Health Overview and Scrutiny Committee, we didn't talk actually very much about discharge. So I think in some ways what's not been said highlights the shift and the change in focus. We are still working incredibly hard, but it's at much smaller cohorts. So it's making less of an impact. But yeah, we have seen some fantastic results, particularly through intermediate care, 30% reduction in the use of res care beds from discharge. And that has been because of an integrated approach really across health and social care partners, particularly UHL and their workforce and LPT. So it is really starting to make a difference, and we just hope that we can continue that. But yes, we will be making sure that in the coming months through the integration exec, we'll be realigning the BCF to kind of not new priorities, it's to maintain our existing priorities, but also for the next year, 2 years, or however long that BCF plan, it shifts to talking about what our new priorities might be as well, and supporting those, particularly around things like Step Up.
Thank you. John?
Yes, thanks. Thanks, Lisa. Just wanted to pick up the point that Rachna was making around some really good positive kind of data in here. At the point around the care technology, I think is one that we perhaps might want to focus on a little bit more this year, in the coming year, because it's one of those, it's a bit like going back to the reports that we had earlier in the meeting, where there's an awful lot going on. It's not all joined up, and there may well be duplication in some areas. And I think that we probably have half a dozen systems across the piece in play at the moment, and perhaps as an opportunity, either through the Health and Wellbeing Partnership or through this board or the Integration Executive, to have a conversation about how we join up that technology so that actually we've got perhaps more, getting added value from the resource that we're all currently expending.
I have actually had tentative discussions with Paula, ICB Chair, and also Caroline, CEO of ICB, on this. So hopefully we can perhaps move things forward on that.
Yeah, and the beauty, I mean, we've largely upped our kind of assistive technology game in the last couple of years, because we've been able to utilise things like the discharge grant, which has been really helpful, because AT discharge grant is essentially, it's almost like a capital fund, isn't it? So utilising it for things like AT is really, really handy. It does mean though, because it's got that separate kind of finance line, we're not always, John's absolutely right, we're not always as joined up as we possibly could be. But I think there's definitely an opportunity there for sure. And it might be worth that we build that opportunity and then align it to the funding afterwards, so that we can take it from multiple streams. That would be probably most beneficial. But I think you're absolutely right, and Rachna is absolutely right as well. Some of the stuff that we've done has led to us having far fewer admissions from care homes due to falls into hospital due to the assistive technology work that's been happening.
That's good to hear. Okay. Can't see anyone else wanting to speak. So we're just asked to note the performance against the Better Care Fund outcome metrics and the positive progress made in transforming health and care pathways up to Q2. And I think we're all very pleased to hear those positive outcomes. Thank you. Are we all okay? Yes. Thank you. Thanks, Lisa. Item 8 is the Better Care Fund Section 75 agreement, pages 171 to 252. This provides the board with an update concerning the refresh of the Leicestershire Better Care Fund Section 75 agreement for 24-25 and seeks approval to continue with the pooled budgets arrangements. And Lisa's going to present this as well.
Thank you. Yeah, me again. Yeah, so as part of our BCF assurance, we have to annually bring the Section 75 agreement. Despite it being a BCF 2-year plan, we still have to bring one every year. It is essentially giving permission, if you like, for the system to pool funds into the one kind of BCF bank account, as I like to call it. It is recommended as part of this report that we continue with that Section 75 arrangement. Just a couple of things to note, that I won't go into the policy and framework decision making that we've previously done. The last one we had was in February this year. I think it was February 29th, if I remember. So in theory, we should see one now every 4 years because it's leap year, but no, so last time was February, this time it's December. So what we've done differently slightly this year is that we've actually got a singular template that we make adaptations from, led by Ratchen's team in the ICB. That gives us one common template across City, County and Rutland, and then we make our own amendments into that. So it's much more aligned as a legal document. For example, there's slight nuances within county. We have different schedules, slightly different schedules. We also have a couple of public health schedules in there, but we also have a schedule for our heart reablement team because we pool funding for that as well. So we have slightly different nuances depending on whether it's Leicester City or County or Rutland. So as part of National Condition 1, we require that the plan for spending of all funding elements is jointly agreed by the local authority and health, and that we agree to continue with the pooling of that funding. Just going on to the attachment, it's fully attached as Appendix A. It's quite a lengthy document. It's quite a lengthy legal document. But as I say, it does underpin all of our plans that we've taken through the Health and Wellbeing Board previously. The key change is that the BCF expenditure plan has been updated for 24-25 and includes the targets for the 5 key performance indicators, which I've just gone through as part of the previous report. In terms of resources, you can see that the expenditure plan for Leicestershire totals 82.5 million in 24-25, and the split for that funding is shown at point 14 on the report. It's hosted by the County Council, and that's it.
Thank you, Lisa. Any questions? Simon?
Fully support this. Thank you. Thank you, Lisa. Fully support this and fully support your previous paper. I was just reflecting on the success that we've seen on the previous paper. But obviously the chair's position statement at the beginning reflected how difficult things are in accessing healthcare services at the moment. So I was really drawn to your comment in the previous paper around ensuring that we continuously look for new areas to have an impact in. And this is an £82 million expenditure commitment. And I think we probably do need to keep on looking for new things to try and alleviate the continued challenges that we're experiencing, noting that if we hadn't had this expenditure this year, the position would be even worse. But how can we use that 82 million collectively to hopefully improve the situation for next winter? Thanks.
Yeah, so Simon, as a member of the integration exec, we are planning to start the BCF planning round at its February meeting, where we will look at the kind of the scheme lines. Each scheme line has got a key line of inquiry document. That's really difficult to say. Attached to it, which tells you where it's commissioned from, what it provides, any staffing, any contracts aligned, etc. So we will be going through each one of those. What I will say about the BCF though is that the majority of which is aligned to support community care and intermediate care. Very little supports acute, and that's probably the way it should be. That's what it's designed for. But what that doesn't stop us doing is actually working in a more integrated way, regardless of the funding. So, for example, we know one of our biggest areas of delay is around P2 discharges into residential care. Very small numbers, you're talking 0.5% of all of UHL discharges, but it still takes on average 10 days. So if we can improve that cohort, just by 2 days by working with care homes, which we're trying to do at the moment to incentivise them to speed up over the winter months. It could potentially save us, 140 days a month, which in the grand scheme of things is quite a low percentage. But that and things like early referrals and getting our teams aligned better can all help to reduce that, and it doesn't cost anything. So the care home incentive scheme obviously will, but there are other things that we can do that don't necessarily have to cost anything. It can just be about better ways of working. So overall, there are very small gains left, if you like, but we're still working on them despite having good performance, because I think that's still really important. So yeah.
Okay, no other speakers. Thank you. So we're asked to note the work undertaken to refresh the Section 75 pooled budget agreement for the Better Care Fund and approve the continuation of the S75 pooled budget arrangements between Leicestershire County Council and Leicestershire and Rutland Integrated Care Board. I think we'd all be in agreement with that. We'd be a bit silly to pull it now. Smasher.
The lead officer names are wrong in the paper. So before I've got a very special pen downstairs. Before I get that special pen out and sign it, can we just change the names to the right officers, please?
Oh yes, okay. Is it the ICB?
I'll send them over.
Yes, please. Thank you very much.
There we go. Thanks, Lisa. Moving on, our next report is the refresh of the Joint Strategic Needs Assessment process, pages 253 to 260. This report relates to the ongoing development of the Leicestershire Joint Strategic Needs Assessment, currently being undertaken on a rolling basis, and seeks approval to pilot a new approach from 2025 onwards. Victoria Rice, Leicestershire County Council, will present this report. Hello, Victoria.
Bear with me a second as I get my text set up. She says. Nope. Try again. There we go. Perfect. So as you're probably aware, the JSNA is a process of needs assessment that is a statutory requirement of the Health and Wellbeing Board. This was made a requirement of the Health and Wellbeing Board back in 2013. And I think it's quite important to highlight how far we've come with health data since that time, and also with technology. So we are looking at changing our approach based on that sort of development of how things are done. So I'm just going to sort of talk through how we currently do things and then what we're looking for going forward. So currently we produce quite long written documents. They're normally around 80 pages, and the time frame to complete these documents can be very long, which makes sense. We want to be thorough and get that data and get that information and make sure it's correct. But sometimes that long time frame does cause us issues down the line, including we don't get to cover everything we'd like to. It just isn't possible in the 3-year cycle we're given for JSNA. And also, by the time we have published a JSNA or brought it to the Health and Wellbeing Board, that data that we collected at the very beginning can be out of date because new data has been released. We have previously, in the last round of JSNA, started doing accompanying dashboards. Not for every chapter, but for the pertinent chapters. So the particular ones that come to mind are the inequalities JSNA that was completed by Sally Valance, and the children and young people mental health JSNA that had a data dashboard attached to it. And these dashboards we try to update more regularly. Going forward, we are hoping that we can move to a dashboard-based JSNA. This would allow us to make sure that the data is up to date as it can be. And also, because it will take less time to update things, we will be able to cover more topics with the prioritisation based on the Joint Health and Wellbeing Strategy refresh. And in turn, the JSNAs will help inform that refresh. It's a bit of a cyclical process. So let me just show you sort of what we were thinking. This is when technology lets me down. So this is just a selection of the type of dashboards and information that my team produce that could be converted to JSNA. I say converted because these are existing products, and also we would like to add narrative to make sure that they are more understandable. So the narrative obviously is writing, so it's the same as a chapter, but it will be less in depth and quite a lot easier to update if it's describing some data that exists. So just to give you an idea of the type of thing that we already produce and are looking to include in the JSNA, in the top left, we've got a dashboard that looks at prevalence of diseases by GP practice, and that is from the QOF data, so that's updated annually. That is something that we could include in the JSNA, as disease prevalence is obviously quite important to future planning. Below that, we've got a strategy board for the sexual health sort of work stream, which that is actually a list of indicators. So that's a very high level sort summary of what's going on in sexual health within Leicestershire. We've then got in the yellow and blue bit of the dashboard that you can see in the centre. That is looking at cancer screening rates by PCN, by GP, but also looking at some of the inequalities data behind that. Below that, we've got an MSOA level dashboard, which is looking at every available MSOA indicator that we could get our hands on from public health. So this is what was used for the inequalities dashboard. And again, that is just so that we've got that inequalities fix on that particular topic. And then the final piece is on the right-hand side is what we call our district profiles, which is a bit of a highlight of data at a district level. So we've got a little bit demographic data, a little bit of wider determinants, and then you can't see it on that, but it's a PDF document with a series of indicators. So what I wanted to show you by showing you these is we are looking to go at the data at the level that is required. So be that at the Leicestershire level if that's what's needed, but we can also go lower at MSOA or district level if that is what would be the most appropriate thing for that topic. As I said, we wouldn't just be including these graphs and maps and things like that. We would have some narrative to continue sort of understanding and so that people know what they're looking at. So this is just sort of some other highlights that I thought were really important to acknowledge when we're talking about this new approach. We are going to continue to present data for the Joint Health Wellbeing Strategy Refresh, which almost has its own mini needs assessment. But as I said before, in turn, the refresh will inform the priorities. We are also, at the moment, it's paused, but the JSNA steering group would help establish what priorities we want to do and also maybe what level the data needs to be at. It's also worth noting that the pharmaceutical needs assessment, so that's the PNA, is still underway in quite a traditional document, just because the way statutory requirements for PNAs work, that is the best way to go. We also have thought that going forward, there is a possibility of getting the health determinants research collaboration involved in certain topics. There are some topics where my team can't get hold of data. So if we can research that topic, why shouldn't we really? And then another really good point is this will also give us more scope to work in collaboration with the city and Rutland. So if there's a particular topic that is needed at an LLR wide level, we can collaborate more, and that can be coordinated through what we already do on a 2 weekly basis of going to an LLR data cell. And then finally, I think this is really important. This is a pilot. We want to try this and see if it goes well. And therefore, we need to put something in place to evaluate it at the end. And I spoke to Joshna about this, and I believe that she's got some people who are evaluation experts who might be able to assist, and the best way to go about that. The two ways we've already thought of is some sort of survey of users of the JSNA, but also because it's all web-based, click-through rates and seeing if it's working for everyone. Yeah, so that's probably about it from me.
Thank you. Mike?
Yeah, thanks, Victoria. I think JSNA for me predates 2013, I'm sure it's 2010 as the first I can think of when public health was in the NHS still. I think you're right. What was originally intended as a kind of compendium, a kind of once every 4 years compendium of everything there is to know is a little bit outdated in technology terms. I did have to remind myself, and I just looked it up, so forgive me reading it out. So if the purpose of a JSNA is to look at the current and future health and care needs of the local population to inform and guide the planning and commissioning of health, wellbeing and social care services within a local authority area, then I think, you know, it fits with where you want to go, because I don't think commissioners would use a kind of once every 4-year report or a series of topic-based chapters, and I know we make use of them. For me, though, I think it is probably two thoughts in my mind, one of which is this needs to be part of an overall approach to data and knowledge management, both within the council, within our partner organisations and within the NHS. So there's a question of, I mean, I don't know if it's a question to answer or a point to take away and just kind of consider how do we publicise it, disseminate it. And then the obvious bit is obviously the way you're suggesting is a new way of doing it. If possible, before we kind of really jump into it, the obvious thing is just to talk to your customers and see what would work for them. So if we've done that already and they've gone, yeah, this is what we want, and that's great. If not, then maybe we should just need to talk to people. And it's not really looking at John, necessarily me and John. I think it's our heads of service, our assistant directors who they should be using it. And if they're not, then what would make it better for them to use?
Yeah, so have definitely spoken to staff within public health in the county council, and I think the main advantage of going for this approach is the accessibility of that data. Having these really long written chapters, you might want one data point from there, and if you don't know where it is, I might do, but then you have to email me to send it to you. Whereas if you have access to a dashboard and you know, if I click this filter, it'll take me to the right place, that's quite accessible, and also the timeliness, as I mentioned before.
I'm still going to email you though.
Yeah,
because I always do.
Yeah.
I suppose, and that's
Right.
fine, but I suppose I want to make certain there's a broader audience
Yeah.
than just people in public health.
Yeah, definitely.
Ed?
Yeah, just to that point, really, isn't it? Because we're always awash with data, but often lacking in intelligence. And I like the idea that this is going to be a much more responsive system which actually will drive policy in the way Mike described. So I think, just to echo Mike's point, really, it'd be good to understand how this is made accessible to partners. I'm thinking district councils and others who would want to shape policy responding to the same truth and not having to reinvent the wheel or use it for wider policy discussions, because I imagine there's similar data sets being created through community safety partnerships and others. And again, a lot of this speaks to similar issues, isn't it, particularly into the wider determinants of health stuff. So yeah, just I think some real practical consideration about how that can be pushed out through our partners.
Yes, certainly we need to think about it. One thing that I think is really important is on a publicly facing website, which if it ever goes down or anyone has any issues with links, please let me know, because it does happen.
Rachna.
Thank you. So a couple of points from me. In terms of all the data that you collect in the old way of doing it, we find it very useful from a strategic commissioning perspective because we can cut and paste. So please don't lose the narrative version of it, because it really does help us when we're trying to write some of this stuff. That said, agreeing with Ed that it's the analysis bit that really helps us. And so the dashboard bit is fine. We can all navigate the dashboard, but I'd be keen not to lose that analysis element, please. Did you say you could drill down to MSOA? Or that's the plan?
It would
for some of
depend
these things?
entirely on the topic and the data, because
that would be really useful for some of the neighbourhood plans that we were looking at earlier, for example, when we're doing things with vaccination and those types of things. That's the real richness of data that we can service plan on.
As much as possible and where appropriate. Some things, obviously, there's going to be small numbers and things like that, but where appropriate, we would go down as far as we can.
Thank you. And my final question, and I appreciate this is almost taking JSNAs now to the kind of next level, Mike, and we haven't talked about this, so I'm just going to put it on the table. We have lots of analysis. We have we know what to do. The bit that sometimes is, quite often is missing, is the economic case for doing that. So if I take something like hypertension, we've got all the data and all the analysis that says we've got this many hypertensives and we should have this many and so on and so forth. So that having it at MSOA date level is really good. But actually, if I were to find 100% of those hypertensives, what does that mean in 10 years' time for the health of this county? And not just the health of the county, then the impact on the wider public sector, on John services, on the Work Well programme that we were talking about earlier. That's the bit of analysis I think we don't do in the JSNA, and just a thought process about whether that's something that we could start thinking about if we are streamlining this part of the process.
Yeah, I think that's a really good point. One thing we are quite keen on is increasing the amount of forward-looking we're doing with the data. Currently, we're quite limited by using population projections that are from 2018. So we obviously want to look forward, and economics isn't something I had considered, I'll be honest, but definitely something we could look into.
And that's probably worth a conversation outside the meeting, because again, there's different ways, isn't there? That, you know, people always say we need a health economist, but you know, are we going to start from scratch? But there is something about using evidence, because there will be evidence and papers that, you know, which we could then scale up in the way that we use some of the national data to inform the numbers in our population. So again, it comes back to maybe a conversation involving Janine Deller as well, in terms of where do we want to go with things like the Health and Equality Support Unit and whatever it's called, data and knowledge mobilisation kind of strategy for Leicestershire or LLR as appropriate.
I get the impression that we're keen on the pilot, but just to make sure we have the relevant people around the table to make sure it will work for everybody. Is that, what have I got to do? Yeah, approve the pilot, new approach to the JSNA. Are we happy with those caveats? Yes, thank you. Thanks, Victoria. Moving on to item 10, it's the Carers Draft Joint Strategic Needs Assessment, page 261 to 360. This report provides the board with the findings of the needs assessment for carers in Leicestershire and asks the board to approve the current draft joint strategic needs assessment as a basis for updating the carers strategy. Hannah Blackledge, Leicestershire County Council, will present the report. Thank you, Hannah.
Thank you very much. It will be the old style, Josie. Let me just get the technology right and get the sharing of the screen properly. Just at the outset, we also have online Sharon Aiken, who's a commissioning lead in the working group. So I think I'll go through a presentation which is mainly needs assessment, and then ask Sharon to sort of ask her to answer any commissioning questions. So I'm here on behalf of a group. Hopefully, oh right, okay, that's showing. It's showing fine. She's back. Okay, so this is, as I said, the old style JSNA, where we start with the needs assessment based on whatever data available we have for it, because it's carers and social care. The information is partly health, partly social care, partly derived from the services. And the reason why we're taking it, that the new carer strategy is in development and will be developed soon. So this is to underpin that strategy from Leicestershire perspective, and in a sense, the whole JSNA would require some clear commissioning conclusions and commissioning guidance on this. So we at the stage where it's a completed needs assessment with conclusions from the data. And sort of we will be adding the commissioning recommendations after the steering group of the for the carer strategy has completed their work. So at this stage, this is in draft, and as a JSNA will also include the commissioning recommendations at a later stage. So I will touch on the document. Has a lot of epidemiology, but also policy context. Has got the current services description rather than directory of current services, and also findings. I don't know why I'm going backwards on this. In terms of background, the carer, for the purpose of this JSNA, is anyone who supports and cares unpaid a person who can't cope without them, manage without them. The carers' contribution to the society has been long recognised, and I know the money is not important, but the estimated contribution is equal to the whole of NHS budget. So it's obviously an important subject with huge impacts on health of the carers and the general sort of health of the community. There are some worrying national trends with worsening financial situation of unpaid carers, increasing numbers of people needing care, emerging from both. I'll have some facts and figures on that, both from the actual demographic trends, increasing number of elderly people, but also increasing numbers of people with multiple conditions. So in terms of policy, all started in 2008, and every 2 years there was a refresh of national policy. The key is the Carer Strategy of 2014, with Care Act and Children's and Families Act, with underpin the responsibilities of local authority in that area. We also had a Carers Action Plan in 2018, and so it's a long history of policy for unpaid carers in the UK. The actual report also shows the local policies and guidance. Important also, around 2012, there is a lot of guidance from NICE. All of this is just to, I'm only skimming through this just to show you what the main report contains. Moving to the needs. Leicestershire has a sort of significant increase in elderly population, and that's where we're different from the rest of the country. It's a much higher growth of over 65s, and we sort of, the estimate is that by 32 we'll have 37,000 more of people over 65, and more than a half of those will have chronic conditions, more than 3 or 4 of them. So the need is growing and will be growing. In terms of numbers, there is a lot of uncertainty about how many carers there is in the community. There's obviously census figures where people declare themselves to be carers, but many do not. And the sort of national estimate for our Leicestershire population would be about 156,000, or 26% of adult population if we apply the sort of national estimates. However, 61.3 thousand in the census 2021 only. Now, other bits of information that we gathered, there is a GP register now for carers, and although the registration is not mandatory and the register itself is not validated yet, it sort of shows about 1 to 2% of adult population only, so about 14,000. So again, a big gap to even to census figures. The people in contact registered with support for carers is only just under 6,800. So again, smaller number. And there've been also figures for young carers through surveys of secondary school population in Leicestershire, and the numbers are again lower than the census figures. So there's clearly some gap in people registering with the services. It's not necessarily the fault of registration. It's quite a few of carers don't want to be registered. So there is a lot under these figures that would have to be clarified, but there is a need for increasing registration. There was nothing in Census 21 which sort of sparked notion that we're different in any way than areas similar to Leicestershire. As elsewhere, the rates within age groups were similar to the national figures. The ethnicity similar as well. There's some variation that nearly 10% of carers now in Wixton against the 9%, but they're not huge. And there is a difficulty adjusting it for age at the moment. So obviously, the older the population, the more carers there are in there. So there is also there was one finding that was actually positive, that the rate of employment for Leicestershire carers was a bit higher and an unemployment lower than national average. So that's a positive. There is still more than 32,000 of carers. 32,000. Actually, it's interesting that the overall proportion of people providing this lower burden of care, which is sort of under 20 hours of care per week, was slightly higher here. So it looks like the carers are providing have slightly lower burden of care than national figures. However, those who provide a lot, there is a very clear link in a minute on with the overall morbidity. I hope that's yes, that's seen better. So that sort of data that you get from census, instead of what's interesting here is the sort of very clear increase with the burden of care, of the rates of disability in those groups, and how stark the effect of caring and burden of caring is on the morbidity and ill health among the carers, and close link to disability. Actually, a huge proportion of carers providing a lot of care are actually disabled themselves. So obviously, the report drills this a little bit more in detail. The other source of data is the carers survey. The recent one for 23-24 only had a 40% response rate, so maybe in some ways, maybe the result may be skewed, but encouragingly, the sort of the proportion of people who had high level of dissatisfaction with services was low compared to the national average in that survey. There were a few things that were of interest. Is that the proportion of carers who care for more than 100 hours have been increasing in the last two editions of that survey, because it's done twice every 2 years. So a 6% increase in those caring for having extremely actually long hours and a bit high burden of care. There is only a half of the respondents said that they can look after themselves, and 70% felt they were neglecting themselves. So again, slightly lower than national average, but a significant number. Again, nationally and locally, the level of financial difficulty is rising, and basically 1 in 10 of respondents said that they had a substantial difficulties because of as a result of the caring role. There is Office for Health Improvement and Disparities. There's a sort of a standard indicator set. Has got a few indicators for the carers, and we surprisingly, despite being social isolation being one of the problems in Leicestershire, that indicator shows us to be slightly better. Still was similar to the areas similar to Leicestershire, so-called statistical our statistical neighbours, but lower than national average. The data usually in these indicators is relatively old, but gives us some picture, not showing us being a particularly outlying area. We had some data from adult social care, and there is an issue with rising numbers of rising numbers of people needing financial support. The direct payments have been increasing by about 30%, I think, over the last 3 years. So again, that gives us some. We have in services. That services section of the report describes each service and whatever data we were getting from them. And what service provides now, what are the current developments and sort of future developments within the service. So obviously adult social care is first. The support for carers service, which is commissioned by adult social care. So the types of services provided, as I said, is not strictly speaking a directory of services, but gives a feel of what currently is going on. Young carer services also the Leicestershire County Council commissions that. The only thing with young carer services of note is that there are some issues now with waiting time. They're not huge, but it's effectively a I think just 2-person service. So the UHL, there's a description of what happens currently at the UHL, also support in carer support in primary care. I've mentioned these. One of the things they do is this carer register, which currently only, as I said, only had about 1-2% of the total registered population. There's a carer support, the LPT and voluntary organisation as well. So these are sort of main sections of that service part of the report. So in terms of the data, obviously there is an issue with identification of carers. It's no fault of any side. It's probably common across the country. So work needed there. That we always need to bear in mind these demographic trends and forecasts, and that multimorbidity issue may bear quite substantially both on the burden of care and of on the provision need for provision. Obviously, whatever we know about has to be taken in the rural deprivation, social isolation, housing and services. All the issues we know about for Leicestershire, they do bear quite substantially on need for care in the community. Yes, carer survey, I said, is done although the return wasn't very high, but response rate, but does give us some feeling what is happening. So in terms of next steps, we'll be still supporting the development of the carer strategy. That there are a lot of all of this has to be looked at from the sort of with a commissioning lens and incorporated into any focus planning for the future. But that much from me, from the point of view of need assessment and old style need assessment. We've got Sharon online as well for if there are any strictly speaking commissioning issue. But any questions for me?
Microphone, could you turn it? Yeah, it's fine. Thanks very much for that, Hannah. I think a lot of issues with the with people actually registering quite often is because they're looking after loved ones and they don't see it as a caring, job as such. They just class it as what you do. And I think that sometimes we have to get people to realise that actually that is a caring role they are providing for their loved one. And by knowing about it, we can do things to help. Was it Sharon? Did she want to come back on anything before we go to questions?
Well, thank you, Chair. I hope you can hear me. I am online. You can hear me okay. So I just wanted to say thank you to Hannah for the work that she's done on this and the team, because they worked really hard to try and find all that different information from all different sources, including myself and our colleagues in health, to get that data together, because it can be quite complex trying to work out all those systems. So I wanted to say thank you for that. I think Hannah was wanting me to make sure that you're aware of what happens next, really, in terms of we have a carer strategy. We have a Leicestershire and Rutland carer strategy at the moment that ends in 2025. So we are just with the group that actually delivers that strategy is called the Carers Delivery Group, that Leicestershire and Rutland Carers Delivery Group, which is a multi-agency group that includes all the statutory partners across the piece, as well as voluntary sector organisations. And we're just beginning to think about how we plan for that next strategy, because it takes, a year to move that through the processes and all the governance that is required for that as well. The first part of that is that we've looked at the current governance of the CCG. It hasn't been reviewed for quite a long time, so we wanted to do a little bit of a thorough work about the governance of the Carers Delivery Group and where it reports to and how it reports, because carers, as we know, is an issue for all of us in all organisations, and how we make the best use of the available resources and the support that we have as in an integrated way is particularly important. So we're all working hard to try and find ways that perhaps the next action plan that we have from the strategy, it has got a sense and is more joined up, because it is quite difficult. Like you say, there's issues about identification that are clearly there that are all of our responsibility. So I think Hannah just wanted to sort of make sure that you knew that this is used, and it certainly is used, and very useful for commissioners to use this data, and then how we'll use that and other things, other consultations, engagements with carers to develop the carer strategy. So I hope that helps to understand its context, but I'm happy to take questions on that too.
Thank you, Sharon. And I was contacted by a group that John is aware of, so if we can make sure they can feed in, that would be brilliant. Thank you. John?
Yes, thank you very much for the presentation. So notwithstanding the conversation we had on the last item, I think this is a really helpful one. As Hannah and Sharon has said, we are in the process of looking at and reviewing the current strategy, and I would hope, I was a bit confused at one point by the comment that the recommendations and the needs assessment will be, we're awaiting the outcome of the strategy discussions, because I kind of think it should be the other way around, that the strategy should be led by the needs assessment. But then I'm thinking, well, maybe it's a kind of co-productive, iterative kind of, and that would be all good in that sense, I suppose, because we get the lived experience along with the data, and then we develop a more rounded approach. The other thing is that alongside the strategy, we're also within the council looking at our carers offer at the moment, and there's a few questions for us in terms, some quite kind of strategic questions around, at the moment we've got quite a universal offer for carers, and do we move to a more targeted offer, and is there more we could be doing, particularly for family carers? I think this report is going to help us to be able to kind of distill some of those questions. So I think it would be really helpful for us in terms of the way we go forward. And the narrative actually is quite helpful, as are the references. So I'm not quite sure where that leaves us with the last conversation. But anyway, there you are. I'll leave that with you.
I think we probably will need a bit of both. I can see the the need for the database is really good for access, but we still need that narrative, as Rashna said. So we will still need some backup paperwork, I think. Thank you very much, Hannah. Thank you, Sharon. Sorry. The board is asked to note the findings of the need assessment for Leicestershire carers, approve the current draft of the JSNA, and agreed to the full commissioner-led recommendations being added to the report once the Carer Strategy Working Group has developed the new strategy in due course. Are we all okay with that? Yes, thank you. Item 11, the draft suicide prevention strategy 2024-29, pages 361 to 432. The purpose of this report is to seek views on the board on the refreshed draft Leicester, and Rutland Suicide Prevention Strategy 24-29 as part of the consultation. This report will be presented by Mike Sands, Fiona Grant and Holly Hutchinson, all from Public Health at Leicestershire County Council. Who's starting?
Well, it's not going to be presented by Mike Sands. Are
you going first, Fiona?
I'll just kick off if that's all right. One of the priorities of the mental health and wellbeing strategy for Leicestershire does include around suicide prevention. So we already have an existing LLR suicide prevention strategy, and there's quite a lot of work, as people will be aware, taking place across the county and indeed across LLR in line with that existing strategy. But there's been a need to update it, and particularly to update it in line with the fairly recently revised National Suicide Prevention Strategy. So Holly has done a lot of the work around that and is going to pick up from there.
Thank you, Fiona. So good afternoon, everyone. So I'm here today to present the draft LLR Suicide Prevention Strategy and seek the board's views as part of the consultation. So throughout the presentation, I'll pull out some of the key aspects that are within the strategy and within the report. Okay, so in terms of context, responsibility for suicide prevention sits with upper tier local authorities through their public health functions. Within LLR, the LLR suicide prevention activity is generally overseen by the Suicide Audit and Prevention Group, which is a partnership group consisting of the local authorities, both upper tier and district and bodies, the ICB, LPT, Leicestershire Police, voluntary sector and lived experience as well. As Fiona mentioned, there is the 2023-2028 National Suicide Prevention Strategy, which we have mirrored within our local strategy. However, the steering group who oversaw strategy development were really keen that the local strategy was based on our own local needs and our local data as well. We've tried to incorporate that as much as possible, and we've been able to use the data provided by Leicestershire Police, the real-time suspected suicide surveillance data, which is a bit of a mouthful. So from now on, I will just refer to that as the police data and the Office for National Statistics data to really understand our local suicides. So the previous strategy, as Fiona mentioned, ran from 2020 to 2023, and that has provided us with some strong foundations to build this strategy from. And although a lot of the priorities and work within that strategy still remain relevant, it did need a bit of a refresh, which is why we're here today. However, achievements from the strategy are covered on the slide, and they can also be seen in the report. However, some of the key ones include the development and delivery of the LLR self-harm service, the expansion of the Tomorrow project to support people bereaved by suicide, and establishment of mental health friendly places and our lived experience network, as well as the ongoing collaboration with Leicestershire Police on the police data. So in terms of the local data, that is highlighted within the strategy and within the report, so I won't linger on it too much. However, there is some key bits to pull out from this. And it's that the majority of our suicides locally, as well as nationally, are within males. And prominent risk factors include self-harm, where 42% of our suspected suicides locally had a history of self-harm, as well as unemployment and within single people as well. In terms of strategy development, it was overseen by a steering group comprising of the 3 upper tier local authorities, the ICB, LPT, Leicestershire Police, PCSE, and we had a member of our lived experience network who sat on the development group as well. As well as utilising the data available to us, we based the draft strategy on quite an in-depth engagement exercise. We conducted focus groups with experts with experience and professionals working within the sector. And the engagement was extremely useful and really enlightening as well. The boxes on the slide, which you probably can't see too well from where you're sitting just now, but they are within the report, show some of the key themes that we pulled out from that. There was a lot of discussion around how we should be changing how mental health and suicide are discussed, so really addressing that stigma and taboo, and then ensuring services are joined up and there's a consistent approach as well. A lot of people picked up on the fact that the previous strategy didn't specifically target children and young people. So they brought that out as a need to intervene early. And there was also quite a few kind of golden threads underpinning principles which ran throughout, which I'll cover in a few minutes. We also used the current evidence base, so the academic and the grey literature, to inform the strategy. We've done a lot of reading on that. And like I said before, we used the national strategy to help inform our local one as well. So moving on to the content of the draft strategy. The diagram you can see before you is taken directly from the strategy, and it comes from an NHSE Midlands Forum event on suicide prevention. And it shows suicide prevention as a bit of a continuum. So suicide prevention can occur at any point across that diagram. And it's something that we've really used to guide our strategy development. So we want to work across the system to ensure that everyone recognises the part that they play within suicide prevention, and so that we can intervene at any of these points. So from promoting health and wellbeing early on to supporting those bereaved by suicide at the end of that continuum. We really want everyone to understand that suicide is everyone's business, and that is one of our key messages throughout the strategy as well. So based on the data, the engagement feedback, the lots of reading of the academic evidence, we simplified the previous strategy, which we hope will help us achieve our mission of preventing suicide and saving lives across Leicester, Leicestershire and Rutland. However, we've also been keen to retain the ambitiousness of it, but also make sure that what we're putting in there is also realistic and that we can deliver against it. So as part of that, we will be developing an action plan to address the priorities, which I will go on to cover in a second. And the action plan will contain specific actions for specific areas based on the data and the evidence, and also the local population. We'll also have different officers from the various different partner organisations that will help us shape the action plan moving forwards, with the plan of having an annual update of the action plan. So this slide basically shows our draft strategy on a page. We have our guiding principles, our key priorities and our key messages, all of which are equally important and all interlinked together to help us achieve that mission in the middle, which is to prevent suicide and save lives across LLR. Into that in a bit more detail. As a steering group, so kind of bearing in mind the groundwork that was conducted, the data, the evidence, the engagement, we devised the following 5 priorities. So they cover children and young people, higher risk groups and locations, of which there is a list. It's not extensive, but there is a list within the strategy document. Improving our local understanding of self-harm, providing effective bereavement support and leadership. And these priorities cover the main risk factors and high risk groups, and they also create opportunities where we can support the system to really understand its role in suicide prevention. And I'll go back to say that statement around ensuring that suicide is everybody's business. The priorities will be delivered utilising our guiding principles of co-production and collaboration, learning from past stories, being data-driven, normalising conversation, so addressing that stigma and taboo, utilising a settings-based approach, and then adoption of trauma-informed practice. I mentioned earlier about kind of golden themes and underlying principles, and this is where they really come in. So the guiding principles were the recurrence themes throughout our engagement and throughout the academic literature, and we felt that these cut across our priorities and would really help us deliver against them rather than being priorities in their own right. So as mentioned, in order to deliver against the strategy, an action plan will be developed. And although it's not been devised yet, this slide and it's paragraph 32 within the report shows some of the potential actions which may be included, such as further advancement and uptake of various training offers for suicide prevention, really incorporating that lived experience voice, working closer with the private sector and primary care, and supporting implementation of mental health and safety planning, to name a few. In terms of the consultation, it is open and it will remain open until the 22nd of December. The draft strategy has been on a bit of a road trip around the system. It's been to lots of different meetings, and I'm sure you have heard about it before this meeting today. And we've also been conducting focus groups with experts with experience. In terms of our next steps, we will shortly begin developing the corresponding action plan in terms of how we're going to address those priorities. We will do the analysis of the consultation responses and make any changes to the strategy, which will then hopefully go to the relevant council meetings in spring 2025 for approval. Then after that, it's probably the more difficult bit, which is the delivery of the action plan. And that is where I will finish. So yeah, thank you. And I guess just that final sentence, together we can prevent suicide and save lives.
Thank you, Holly and Fiona. Anybody? Yes, Simon.
Thank you for the helpful update and the work on the strategy. So there's some data in the main pack on 388, which articulates a steady growth in Leicestershire population residents who have committed suicide up to 2022. Do we know, the first question, if that trend's continued beyond 2022 into 2024? And it was great to see the successes on the slide. Are we comfortable with those successes given the rise in suicides that we are experiencing, noting our efforts to prevent them from taking place? Thanks.
So yes, we are seeing that growth continuing, unfortunately, and it is reflecting a sort of national increase in suicides. So whereas a few years ago there was more of a downward trend, there was a point at which, say 2018, it sort of started to go up again, and we've seen a bit of an increase since then. And which is it's unfortunate because there obviously is a lot of work being done to try to address that, but there are so many complex factors involved. It's quite difficult to mitigate against everything.
Jean?
Thank you. Just turn your, oh, sorry. I'm getting good at this. I just wanted to say thank you. I thought it was a really helpful paper. I think one thing that I applaud you for is the inclusion of the neurodiverse population and what we're seeing in terms of an increase in mental health challenges for that population itself. And I think we had a meeting yesterday in terms of some of the crisis work in mental health. I think it was recognised in that actually that population of individuals, particularly those who are undiagnosed and therefore aren't on active treatment, we are seeing a much bigger increase in people that are seeking crisis support, and particularly, fortunately, going on then to completing suicide, which is very sad. So I'm really happy to see that in there in terms of that reference.
Hold it.
Thank you. So I apologise if this is going to sound a little bit petty, actually, but just to acknowledge the work, and I know that we have had only this week, Val a safeguarding concern on one of our projects around suicide, and we're seeing a lot more on the ground as well. But when I was looking at the consultation list, I couldn't see any voluntary community social enterprise organisations listed or any faith groups. It was before my time, but I do believe Healthwatch had produced a report. Might have been around male suicide, so apologise if that's wrong. And also, I know Samaritans did some work around the economic costs, so I know that this might have been flagged previously, but I just wanted to flag it again, so thank you.
Thank you. Fiona flagged the exact same points when we came to scrutiny. We have made sure that we used the learning from the Healthwatch report on male suicides within the report. Yeah, this has been recognised.
Just in terms of the point about VCS engagement, yes, so there has been quite active engagement of VCS organisations throughout the process. So that's included, for example, linking in with the LLR VCS network and with others as part of that. And it's even included, there was an initial piece of work done even before a lot of the work around the strategy started, where we got the views of the VCS, and that was fed into the work of the strategy.
Thank you. Does that include faith groups as well?
Yeah. Yes, as part of the wider network. And I know you mentioned Samaritans as well, and they were part of the steering group. So they helped kind of write and develop the strategy as well.
Okay, thank you. I did assume so, but I thought to ask. Mike?
Yeah, thanks, Chair. I kind of know the answer to this, but I'll kind of ask it anyway. We have the annual delivery plan. There's a couple of thoughts in my mind. Where do we take that anywhere outside of the SAPG for awareness? And then I'm thinking, and I suppose I'm thinking that here is a 4-year strategy which sets out kind of broad things, and we have an annual delivery plan, which, I mean, to be blunt, I'm thinking, the trends in how people die by suicide change over time, and then after a while we normally take action on national level. So it was town gas, got rid of that because natural gas came in. Pack sizes for paracetamol in response to overdosing, gassing yourself in your car, catalytic converters largely put paid to that one. So there's a kind of grim conversation for a dinner party. So there's kind of like a midway point, isn't it? Like annual, you wouldn't go and change everything you're doing to take account of trends unless there was a cluster. And yet somewhere there's a bit of a check in a 4-year cycle, just in terms of is there, that kind of mid-range of, is there a kind of change going on? And I suppose I'm thinking at the moment, over the last few years, we might have had a focus on rail safety, but people will be aware of some of the stuff we're seeing in relation to motorways, for instance. So and again, I don't want to spark kind of contagion and get people to think about it, but I suppose there is that balance between what's the right timescale to respond to these kind of more bigger trends, or if you like, or changes in suicidal methods, I suppose. I don't know if that's answerable or not.
I mean, we try to, obviously some trends sort of happen in quite a short space of time. So we do, through the real-time suspected surveillance data, we do monitor methods. So if there was anything new, then we would be able to sort of try to address what we're doing and probably sort of tailor what we're doing through the action plans to try to address that. The most common method is hanging still. So in terms of we do monitor it, and we try to build in flexibility of response. And in terms of reporting on the action plans, it feels as if we'd be reporting on an annual basis, but maybe every 4 years is probably that kind of review of if there's anything kind of very significant, I suppose, that would require us to do something quite different than the existing strategy.
Can't see anybody else wanting to speak. I think, oh, sorry, Holly, do you want to come back?
Yeah, thank you, Chair. Just to say as well, I guess that the data that we can access changes as well. So the business intelligence team working with the police are always looking at ways to advance and capture more data. I know there's a desire to look more at the intersectionality of that data as well. So things like that will factor in throughout the life cycle of the strategy.
I think one of the things perhaps public would see was the numbers are relatively small, but it's the actual impact, not just with the families, but with work, colleagues, with HGV drivers who may witness things. So it's the cumulative effect as well, isn't it, that we're trying to mitigate for as well. Okay, thank you. So we're asked to note the update on the development of the Suicide Prevention Strategy 24-29 for LLR, and that officers be requested to consider the comments now made as part of the consultation on the strategy. And I would also ask that if members haven't input to that and have other thoughts, please do so before the consultation finishes. So we're happy with that, everybody? Yes? Yep. Thanks very much. Thanks, Holly. Is it? Happy birthday, Holly. I didn't realise it was your birthday. What a way to spend it. Little bird in my ear. Item 12 is the Joint Local Health and Wellbeing Strategy Progress Update for the Mental Health Subgroup. This is pages 433 to 440. The purpose of this report is to give a progress update on the mental health joint local health and wellbeing strategy priority areas, and this report will be presented by Fiona Grant, Public Health, Leicestershire County Council. Thanks, Fiona.
Thank you. So as part of the recommendations, the Health and Wellbeing Board are requested to note progress underway and support the ongoing activity to deliver these actions. So the mental health subgroup of the Health and Wellbeing Board was established in February 23, and as well as being a Health and Wellbeing Board subgroup, it also acts as a place-based group for the Leicester, Leicestershire and Rutland Mental Health Collaborative. And since then, the group has become very well established with representation from quite a range of partners, including County Council, LPT, ICB, voluntary community sector, districts and boroughs. And as part of the work, there are a number of different priority areas, and those priorities have been drawn from the mental health element of the health and wellbeing strategy. They've also been informed by some of the recommendations from the adults and the children's mental health GSNAs, and also from the development session that was held of the Health and Wellbeing Board in December 23. So there are a number of key elements of the work, and the work ranges within that group from children, young people through to people with dementia. So it is quite broad ranging in terms of the scope of the work of the group. Key priority areas include children and young people, so really supporting and enhancing the CYP offer around mental health and wellbeing and including prevention. And I won't go through everything, but just sort of pick out a few key highlights. Around serious mental illness, there's a real recognition of the sort of reduced life expectancy of people with serious mental illness. So quite a focus on what we do about that and how we address that health inequality. So that includes, so for example, looking at improving health check uptake and follow-up support for people who have serious mental illness. We've also identified a priority around people with mental health issues experiencing severe and multiple disadvantage. So sort of, and this is one of the things that came out of the adults mental health GSNA, really recognising that many people will have sort of several different factors that work together and make life much more difficult for individuals with serious mental illness. It might be combining serious mental illness, for example, with trauma, homelessness and or substance misuse. Other areas include suicide prevention, which we just heard about, and also dementia. And so I've detailed the sort of the progress against some of those priority areas, but they include, for example, the work around mental health friendly places that is really being rolled out across the county, the LLR Tomorrow Suicide Bereavement Service, which Holly mentioned just a few minutes ago, making every contact count training, start a conversation website. Also, for example, the Voluntary and Community Sector Prevention and Resilience Grant funding, which was funding received via the ICB, which we were able to use to fund a number of different community and voluntary sector organisations to do some work around mental health and wellbeing. We've also embarked on a project around serious mental illness and health inequalities and looking to improve breast screening uptake amongst people with SMI, because we've identified that through the adults GSNA that appears to be a particular issue. So that's just to give you a few examples, but obviously there is much further detail around that within the report. As I mentioned, there was a development session held in December 23, and there were a number of recommendations that came out of that, and that included identifying and understanding opportunities for proactive and early intervention, making sure we routinely focus on the person's perspective, so that sort of customer journey, and having consistent information across the whole system communicated in a way that people and residents understand. So that whole point about people not quite knowing where they can get help and support and not knowing how to access it was one of the key themes that seemed to come from that development session. So progress to date around those areas include working closely with VCS through VCS engagement, particularly through the VCS network, to help understand issues from a user perspective and also from the VCS perspective. As part of the suicide prevention refresh, engagement of members of the Suicide Prevention Lived Experience Network to really inform the whole process around the development of the strategy. Working with children, young people, mental health commissioners and providers to try to support the implementation of the range of pathways and support appropriate to different levels of need. So it's recognising that we often talk about access to specialist mental health services such as CAMS for children, young people, but it's really recognising that there are a number of different levels of service going to that sort of prevention, resilience building level, if you like, and it's really trying to make sure that we have service provision from prevention resilience all the way through to that more specialist level, and that again that people have an awareness and an ability to access those services. So there's work going on to really try to support those providers and commissioners around that. The other work I mentioned previously was around really working across the system in this work around this breast screening project. And finally, through working in collaboration with partner organisations supporting the rollout of the social platform Joy app to sort of try to sort of enable that again, that better awareness, that better communication of services and pathways of access. So there is much more detail in the report, but that hopefully gives you a flavour of the work that's been done and of the progress that's made against some of those key priorities. Thank you.
Thanks, Fiona. And I think in the relatively short time, it wasn't one of the original subgroups for the Health and Wellbeing Board. So I think there's been quite a lot of work already achieved through that. So thank you. Does anyone wish to speak? Or yes, Rachna.
Thank you for the update, Fiona. So this is a really good example of where we're doing things at system level and place level and neighbourhood level. We're being able to bring it together in a really positive way. So just a reflection, Chair, about how we might get some of our other partnerships and collaboratives that we've got from a health system perspective that work with local government to work in the same way. So just a thought process about how we could spread that best practice. And my second point, Fiona, we're going into a very difficult 25-26 planning round, which, as everybody knows, will have limited public sector funding across the board. We've got so many small grants or small pots of money that we've quite rightly worked with the voluntary sector or smaller organisations to deliver. It's the economic return on those that we're really struggling with. And that means my worry, I guess, is that as we go into 25-26, because we can't evidence what we're effectively getting for that public pound, that we'll do the easy thing, which is to divert it elsewhere, which is absolutely not what the intention is of either the ICB or colleagues around this table. So just your thoughts on whether we have anything that would help us as we go into 25-26. Thank you.
So for example, I suppose one of the ways that we can contribute towards that was the work where we've allocated, we mentioned the ICB funding to fund neighbourhood and community projects. A key part of that was building in quite robust evaluation for each project that was funded, and we are now getting back those evaluations and we're collating those. So that's part of that was very much with this in mind, is that how can you demonstrate the value and how can you demonstrate the outcomes of those pieces of work. So we'll be looking to pull that together, and hopefully that will help to justify some kind of continued support to some of those organisations where they're making a difference. But I guess it also sadly flags up where we're not seeing the outcomes that we might have expected to see.
Pardon? Yeah, just to touch on that a little bit. So yes, we were involved in looking at the way that we can measure impact for that piece of work and speaking to community groups about what they feel they can achieve and where they need support. So I know that we fed that in, but going forwards through the infrastructure contract at VAL, that is something we are looking at and keen to develop. So actually some communication about how we can improve or strengthen that, we would welcome. So.
Thank you. Don't have anyone else wishing to speak. So we're asked that we note the progress underway, including the actions related to the December 23 development, that the board supports the ongoing activity to deliver these actions. So we're all okay with that? Yeah, thank you. Thanks, Fiona. Thanks everyone for bearing with us. It's a long agenda getting through. Item 13 is the Joint Local Health and Wellbeing Strategy Refresh Proposal, pages 441 to 444. The purpose of this report is to provide an outline proposal for the Joint Local Health and Wellbeing Board Strategy Review due to commence in February 25. Victoria Charlton of Leicestershire County Council will present the report. Thank you, Victoria.
Chair, I won't take too long, I promise. So just to recap, really, the strategy is informed by the needs identified in the Joint Strategic Needs Assessment, and it sets out the vision, priorities and actions agreed by the Health and Wellbeing Board to improve the health and wellbeing outcomes and reduce health inequalities, the communities of Leicestershire. The strategy comprises of a life course approach and the 4 Health and Wellbeing Board subgroups responsible for delivering those commitments within each of the life courses. So the strategy is a 10-year strategy, and it was approved back in February 2022 with a view to have an in-depth review after 3 years. So really the proposal today really was just to go through that and outline that to yourselves. So back in July 2023, we had a Health and Wellbeing Board development session, and out some of those discussions, it was agreed by board members that the life course approach was the right approach to take, and it also aligns to the LLR Health and Wellbeing Partnership Integrated Care Strategy. So the review will be based on the commitments within the life course and not the life course itself. So just as you mentioned, Chair, so the review is intended to commence in February 2025 and then conclude by September 2025. It will be informed by the Joint Strategic Needs Assessment, and it's proposed that the subgroups will assess the commitments in each of the life courses and then advise the Health and Wellbeing Board of any proposed deletions, alterations or additions and provide a rationale. And this will be presented at the Health and Wellbeing Board back in September 2025. Just really want to highlight that the review is an opportunity to carry out a sense check of the priorities. It's not a refresh or a rewrite, and so because of that, on that basis, the proposed approach for the consultation and engagement will be as follows. So we're planning to engage with the voluntary sector partners, and we'll coordinate that through VAL. We've already had those initial conversations.
We will consult with the Health Overview and Scrutiny Committee, and that will be prior to coming to board in September, just to seek feedback. And then we will inform the Health and Wellbeing Partnership of the revised strategy, any sort of changes to the commitments once it's been approved at board in September. And then if approved today, the intention is to come back to the board in February 25 with sort of a confirmed approach, and then obviously set out the agreed timescales for delivery and those key milestones. So that's it. So very short and sweet, but
Any questions? Hello, Hardy.
Yeah, just to add, so we have had those initial discussions, and it will be a coordinated both VAL and Healthwatch approach.
See anyone else wishing to speak? So we're asked to approve the suggested approach to carrying out the JLHWS review. Included the suggested approach to carry out the consultation engagement, agree the timescales for delivery as set out in the report. Are we all okay with that? Thank you. Yep, thank you. Thanks, Victoria. Item 4 is the annual report for the Director of Public Health, pages 445 to 484. This report presents the Director of Public Health's annual report for 2024, which this year focuses on inequalities in health. The report will be presented by Mike Sands, Director of Public Health. Thanks, Mike.
Thanks, Chair. Yeah, it's been a lengthy meeting, so I won't dwell on this one, but it is to present my annual report for this year. To remind you, I didn't produce an annual report during COVID, so I picked up the reins again last year with a report that just looked at the overall health of Leicestershire's population, which, as you would expect, found that Leicestershire was a relatively healthy place overall, but there were a few at that stage kind of broad categories like obesity and diet, which we needed to do better at. I said at the time that this year I wanted to drill into that detail a bit more and understand more about the groups that had worse health within Leicestershire. This is what that report does. If you read it, if you have read it and think, I'm sure this looks familiar, it's because I've fairly shamelessly realised that the Health Inequalities chapter of the Joint Strategic Needs Assessment, which was only produced last year, pretty much covered everything I wanted to say. So I've nicked it, I've condensed it, I have updated some of the data where it's available to be updated, just to give it a bit of a refresh, but some of the data is the best we've got. So there's quite a lot of data in there, but I suppose the main bit is, for me, it then all points to the groups and areas that are outlined in paragraphs 12 and 13 in the covering paper, in terms of, from a Leicestershire perspective, if you consider the health inequalities considered by those groups, and then think about Leicestershire's population as well. So there's an element of scale and impact in there. Paragraph 12 outlines those groups, and paragraph 13 considers the geographic areas at a MSOA level, middle super upper area level, which also experience the worst inequalities. Like in the Health Inequalities JSA chapter, those in bold are the ones in particular, in terms of the paragraph 12, the groups that are at special risk of experiencing health inequalities. So that's there. In terms of recommendations, I'm always loath to put sort of a load of naughty recommendations in, pointing fingers at people. So I've made them much more about my own department. I think there are challenges for us, which are about understanding from our delivered services in-house. Are we capturing data on health inequalities, and are we really using that to drive service redesign? And at the same time, I think there's then that kind of the second bit of that is then following through and demonstrating that we've actually not just got the data, but we are doing something about it. So if there is I've not put it as a special recommendation, but clearly from my point of view, I can say that to my department. I would encourage you all to go back to your own constituents, departments and organisations to also think from a Leicestershire point of view, what does this tell us in response to how are we responding to these inequalities groups? I think particularly from an LLR perspective, of course, Rachel talks about system, place and neighbourhood. At a system level, of course, given the level of inequality and poor health and deprivation within the city, it sounds horrible to say, but it kind of crowds out the kind of LLR perspective. And I can understand why, But I guess I want the report to be there just to remind people in terms of Leicestershire that it is a different picture, that although it's relatively healthy, we have got groups at severe risk of inequalities. And we do need to, through the place-based work and maybe through consideration of parts of the system, respond to the priority groups for tackling health inequalities within Leicestershire. So as always, and we say at the end of this, make of it what you will. But again, if partners are interested, want to get in touch with me around presentations or explaining more, I'm more than happy to do that. So thank you, Chair.
Thank you. Anyone wish to make any comments, Rachna?
It might be worth thinking about whether we take this to ICP or ICB, one of them, because as Mike says, we talk a lot about the inequity that we see in the city quite regularly. This gives a really good flavour actually about what else we need to think about. So maybe it's something that we should put on the agenda.
Thank you. Good suggestion.
Yeah, it is a good suggestion. And I should have said, I mean, coming back to the kind of, I think somebody said intersectionality earlier on. So one of the points we're making there is actually poverty and deprivation shoots all the way through, and that doesn't matter whether it's LL or R. It's, you know, relative levels would be different, but not the rest of it. But then those groups, you know, would equally be relevant to some degree across the city and indeed in Rutland. So the idea of looking at homelessness, for instance, across the piece, or LGBTQ plus, you know, there are cross-cutting things which we could take forward, or at least be aware of at an LLR level as well as L.
Thank you. So we're asked to note the Director of Public Health's annual report for 2024 and the recommendations in the report, and agree to take the DPH annual report into account when reviewing the JLHWS. We're okay with that. Thank you. Our final report is the protocol between the Health and Wellbeing Board, the Health Overview and Scrutiny Committee and Health Watch Leicestershire. This is pages 489 to 510. The purpose of the report is to enable the board to consider proposed changes to the protocol. Ewan Walters, Democratic Service Officer for Leicestershire County Council, will present the report. Thanks, Ewan.
So the purpose of the report is to set out the roles and responsibilities of the three bodies and make sure that they complement each other and are not duplicating and stepping on each other's toes, etc. And the protocol was first agreed in 2017, and as I'm sure you can imagine, a lot has changed in the health landscape since then. A lot of terminology needs changing, etc. But in terms of the substance of the document, we're not proposing that anything changes. It just needs updating in terms of clinical commissioning groups have become integrated care boards, terms of reference of health and wellbeing board subgroups have changed. And then the other major change is to do with local authorities used to have a power of referral to the Secretary of State about health proposals. That went in January of this year. So we needed to just amend the wording in the protocol, because now local authorities can write to request that the Secretary of State intervenes, but they don't have quite the same formal power anymore. So yeah, it's just a question of updating the terminology, and it's not really any major changes.
Okay, thank you. I don't think we've got any questions on that one. So we're asked to approve the revised protocol between the three boards. Is everyone happy with that? Yes, thank you, Ewan. The date of next meeting will be Thursday, the 27th of February 2025 at 2 o'clock. Item 18, any other items which the Chairman has decided to take as urgent. As I mentioned earlier, I'm taking the urgent item relating to the pressures on urgent and emergency care. So I'm going to ask Rachna to say a few words about that. Thanks.
Thank you, Chair. And of course, I've got Jean and Simon here as well, who feel free to add, amend, supplement. So Chair, as you requested, I gave you a brief update, which I'll just very quickly recap. So we've had some of the busiest days that we've seen on record across the Leicestershire system, but we've also seen that regionally and also nationally. So the picture is replicated up and down the country. We've got a high footfall into the emergency department. We've got a high call rate at the moment into the East Midlands Ambulance Service. We've seen a spike in patients who have been admitted for flu, and we're seeing increases now in COVID-related admissions as well. John services, of course, remain under pressure, as well as partnership services to then get people back safely in their own home. So as part of your statement, Chair, just request to make sure to our residents around vaccinations and making sure that we are using our general practices appropriately as we have been working with our residents to do so over the course of the last couple of weeks. The measles, pertussis and RSV vaccination rates have also gone up, which is a good thing as a result, I think, of all the partnership working that's happened across the patch in the last kind of 3 or 4 months. But we do still remain in some areas of Leicestershire in some of our lower quartiles, and we've got more work to do to make sure those vaccination rates are up so that our residents are protected. We have got GP collective action as well, which is ongoing, so we're working with our general practices to work out the impact of that and how we can make sure residents can get safe access to care. We'd urge residents to seek access to care through 111 and the 999 services they normally would, and to support us through that vaccination programme as I've asked, Chair. Thank you.
Does Jean or Simon want to say anything?
Thank you, Rachna, for the update. Totally support that, and for the remarks of the chair at the beginning of the session. So Stephen Powis today referred to admissions due to flu being 4 times greater than the same period last year, and he's referred to the potential of a triple-demic of COVID norovirus and RSV, but also with flu that could be what he's referring to as a quad-demic of challenges this year. So your point, Chair, about seeking alternative options via 111 and other options such as Pharmacy First are key for us. And I echo Rachna's point about working in partnership to make a difference for our population. Thank you.
And Mike?
So as a question and a comment, so I was just reading that as well, Stephen Powis's thing. I suppose in relation to flu is an interesting one because 4 times this time last year sounds a lot, but that's because there wasn't very many cases this time last year because the flu season kicked in a bit later, which then I suppose is where he's coming at in terms of a potential tridemic, quaddemic. That same article, he said, I think the BBC have said, beds are 95% full. Now, part of me thinks if we ever get down to 95%, we'll be looking pretty good. So in terms of UHL bed occupancy, what are we on at the moment?
Thank you. I think I'll have to get that specific figure for you, and if that's okay, provide it to you, because I don't have it offhand. But what I would say is your position on regularly exceeding that figure is correct for us. It does vary per site, with Leicester Royal often hitting over that consistently, but less at the Leicester General. But I'll get the exact figure and provide it to you in for the notes.
I'll do.
It was just to say that our Health Watch Chair and Vice Chair, Fiona, who will attend this meeting, are having discussions outside with UHL and ICB on this as well. So there is definitely a partnership approach.
Yes, Jean.
Just to answer Mike's question, really. So we've got escalation areas open in LPT. There are escalation areas open in UHL. We are putting using our boarding capacity as well. So it's more than 100%. I think it's probably fair to say. And thank you to Health Watch, because they've been supporting us in terms of some of the communications out to the public, so they're aware of the best option for them to choose, which probably isn't sitting in an A&E when it's as busy as it is at the moment.
Thank you for those updates. I think it's really important for the public to understand how pressured the system is, especially at this time of year, but this year has been pressured all the way through, hasn't it? So final point is it's Victoria's last meeting with us. Victoria's taking on a different position. So I'd like to put on record my personal thanks for all she's done. We've made big inroads with the Health and Wellbeing Board, while you've been here. We've taken it to a totally different place. It has its recognition within the system, and it hasn't been plain sailing all the way through. There's been lots of challenging conversations and discussions to overcome, and you've done that with real professionalism. So thank you very much, and I wish you well in your new role. So that concludes the meeting. Oh, and it is 5 o'clock just, so we're all right. I managed. Thank you. Safe journey home.